My name is Devoka Gordon. I am with the patent system. I'm at my office in Pittsburgh. Also in the back we have Katrina Mallett and Liz Mayer from the Harrisburg office. If you are in the session for establishing rule following in home, school, and community settings among students with autism and related disabilities, then you are in the correct session. I just have a few housekeeping chores I'd like to take care of before I introduce our presenter. The exhibit hall, I guess and I know if you've been here since yesterday, you already know probably these announcements. The exhibit hall is open until 5 o'clock today. And remember, in order to get your continuing ed credits, you must complete and hand in a verification form at the registration desk prior to departing on your last day of attendance. This is where you put the codes given at the end of each presentation, and I do have code. I'll have a code for you at the end of this session. And you can access the PowerPoint and any handouts for this session via the conference website or Groupio app. We're also asking that upon the completion of each presentation that you give us feedback for that session via the new Groupio mobile app. And that's it, I think, for our housekeeping chores and our announcements. We will be taking a break at 2:30. Maybe you shouldn't announce that, because then you'll start holding us to that, you know, when you start looking at your watch. But at 2:30, we'll take a 15-minute break with the snacks that'll be out. And with that, I would like to introduce our presenter, Dr. David Wilder. He's a professor and chair of an open campus programs in the School of Behavior Analysis at the Florida Institute of Technology in Melbourne, Florida. He earned a PhD in psychology with an emphasis in behavior analysis from the University of Nevada under the supervision of Dr. James E. Carr. He then completed a postdoctoral fellowship in the Department of Behavioral Psychology at the Kennedy Krieger Institute and the Johns Hopkins University School of Medicine. And Dr. Wilder has published over 70 peer-reviewed journal articles and serves as an associate editor for the Journal of Applied Behavior Analysis and the Journal of Organizational Behavior Management. He's also on the editorial boards of Behavior Interventions, Education and Treatment of Children, and Behavior Modification. He served as president of the Florida Association for Behavior Analysis and the Organizational Behavior Management Network, and is a recipient of the Outstanding Scientific Contributions to Behavior Analysis Award from FABA. Dr. Wilder consults at the individual and organizational level to schools, private homes, hospitals, group homes, and day treatment centers, and is a board-certified behavior analysis. And with that, could you help me in welcoming Dr. Wilder?
Okay, thank you, Devoka. First off, can everyone hear me in the back of the room? Everyone can hear me okay? All right. No? Is that better? No? Okay, I think the mic is on, but it may not be. Sounds like I have to talk directly into it, huh? I had it on my tie, but I'm not sure that's going to work. Okay, well, I'll just try to talk into it and hold it. Maybe at the break I'll figure something else out. First off, I want to thank Mike Miklos and the organizational team that put this conference together. This is the second time that I've been at this conference, and I'm impressed both times that I've been here. There's a lot of people, a lot of interest in autism, and it's great to see. We don't, in Florida, which is where I'm from, we don't have a state conference like this, so it's always nice to come up here and see all the interest in this topic. I'm going to say a little bit more about myself. Devoka gave a great introduction, but just so you have some background about me and who I am, what I do. I'm a professor at Florida Tech in Melbourne, Florida, and I'm the chair of our master's and PhD programs in behavior analysis. and we have 4 programs, on-campus programs. We also have, as some of you may know, some online and hybrid programs, but I don't have anything to do with that. I'm just involved in the on-campus programs. So I supervise students, and I teach, and at Florida Tech we have a center called the Scott Center for Autism Treatment. It's an on-campus center for kids with autism between the ages of 2 to really adulthood, although most of the kids are between 2 and I'd say 12 or so. So I also do some work there at the Scott Center, is what we call it. I supervise students there and I actually take some cases there. And much of the data and the stories that I'll be sharing with you today come from my work there at the Scott Center on campus at Florida Tech. I also want to mention that Devoka said that you can see the slides for my presentation online, and although that's true, I did send them in. The file that I have was too large to send in its entirety, so what I'm going to show you is a larger view than what you'll see just online. Just keep that in mind. And I have no problem sending you this slide. If you, in fact, at the end of my talk, I've got a slide telling you how to contact me if you'd like a copy of these slides. I'm happy to send them to you. I can send them in a zip file, I think. I couldn't send them for the program. There was a special program that you could use to send them, but even that program wasn't large enough for my PowerPoint. I think I've got a lot of pictures. Okay. So the title of my talk is Establishing Rule Following in Home, School, and Community Settings Among Students with Autism and Related Disabilities. And what I'm going to try to do today is first define compliance and describe why it's important. Then I'm going to talk about assessment of compliance or non-compliance. And then I'm going to move into treatments. And I've separated out the 2 types of treatments into antecedent-based interventions or treatments and consequence-based interventions or treatments. And then at the end of the presentation, if I have time, I'm not sure I will, but I do have some exercises. I brought some paper handouts. I know we were going paperless this year, but I brought some anyway. Some paper handouts if we have time to do at the end. If not, then I can email them to you if you're interested. So first off, I'm going to start by defining compliance and non-compliance and what it is and why it's important. One of the, let me tell you a little bit more about the Scott Center again before I get into the gist of this. That's where it was before, but it wasn't working. No. Okay. Can you hear me in the back of the room? You can? Okay, great. So I don't have to hold it. Thank you. At the Scott Center that I mentioned earlier, we have a wide range of kids that we see. Many of the kids, we have an early intervention program, we have a severe behavior program, we have a feeding disorders program. So it's we provide a number of services to kids, mainly with autism, in the local community and really statewide. One of the kind of specialties that we've developed at the Scott Center is the assessment and treatment of compliance problems in not only kids, but also adults with autism-related disabilities. So that's, again, where a lot of this comes from. So first let me define compliance or noncompliance. It's often defined as doing what is requested in an adult-delivered instruction within 10 seconds. So, in other words, an adult asks a child to do something, whatever that may be, and if the child complies within 10 seconds, we're counting that as compliance. The 10 seconds number is a bit unusual in that, maybe not unusual, but there's a lot of variability in what people consider, what parents, teachers, and others consider an appropriate amount of time to allow a child to comply. And in the literature, and there's been, I'll show you some of the literature later in the talk, but believe me, there's been a lot of studies on this, a lot of studies on compliance going way back into the 1960s and a lot recently, but really way back there's been research on this issue, both with typically developing kids and with kids and adults with disabilities, such as autism, but not only autism, other intellectual disabilities as well. In the literature, oftentimes that 10 seconds is the modal number that's given, the amount of time that the child's allowed to either initiate or complete a task to count that as compliance. But it depends on the child. Sometimes at our clinic at the Scott Center, we'll use, depending on the the functioning level of the child we're working with, we might use 6 seconds. In other cases, we might use 30 seconds. But 10 is about the modal. So in other words, what we're saying when we're talking about compliance is, does the child comply, or at least initiates the task that the adult, teacher, parent, whomever has asked him or her to do within a reasonable amount of time, and we're using 10 seconds for that. It is, you may or may not know that it is the most common childhood behavior problem. So a lot of people, when I talk about this, they say, well, why are you focusing, why are you doing research, and why are you so interested in compliance when there's so many other behavior problems that exist, right? Especially in children and adults with autism and related disabilities, there's more severe behavior problems like self-injury or aggression, or sometimes even things like property destruction can be more damaging in a sense, more severe. And my response to that is, that's true. Although with all of the behavior problems that were just mentioned, self-injury, aggression, etc., compliance is a component of that, right? In many cases, compliance is a component. It may not be the only thing that's involved, the only variable that's involved in terms of why these individuals are engaging in these behaviors, but in almost every case, compliance is a component of that. So it's important for that reason. It's also important because we see a lot of kids for whom if they don't stop doing or start doing something that a parent or a teacher has asked them to do, they then put themselves in danger. In other words, compliance itself can be important, even if it's not a part of another behavior problem. And probably the last reason here is, as I mentioned on the slide, it's the most common behavior problem. There's been a number of, I've cited one here, but there's been a number of studies done in outpatient clinics, pediatricians' offices. Some of you may know that in pediatricians' offices, the number one complaint or concern by parents is not physical, it's not medical, it's behavioral. And of all the complaints, the parent comes in and says, my child won't do what I ask him or her to do. And of course, this is not only with kids with disabilities, but also with the typical developing population. So it's pervasive. Another reason it's important to focus on and to come up with better ways to assess and intervene on is that it's negatively correlated with a number of psychiatric diagnoses later in life. And this is mainly for typically developing kids, although it can apply to kids with disabilities as well. There's a number of psychiatric diagnoses that folks get in adolescence or young adulthood, such as ODD, oppositional defiant disorder, some of the personality disorders. Those disorders are correlated with compliance problems at an early age, between the ages of 2 and 6. Right? So if a child is having compliance problems at this age, there's an increased likelihood of getting some sort of maybe more serious adult diagnosis later on in life. So it's important to address compliance at an early age for that reason. For kids with disabilities, which is, I'm guessing, most of our concern, compliance problems has been correlated with academic progress. In other words, for kids who don't make good academic progress, oftentimes you can, and who have a disability, you can look at them and find that they had compliance problems early on, right? And this makes sense. Much of the progress that we make in school is dependent upon being able to follow instructions when we're young, right? When we first start out in the school environment, when we're learning. So if we're not following instructions correctly or competently, consistently, then we might have academic progress later on. It's also predictive of problems with compliance at a young age are predictive of more severe behavior and more frequent problem behavior, other types of problem behavior later on for kids with disabilities, including autism. And I'll show you an example here of, there's been a number of studies that have shown this, but the one I like to talk about and show is this. It was published over 35 years ago in JAMA, and they looked at, was Dennis Russo, who was at the Kennedy Krieger Institute at the time, and they had 3 kids, and the focus of what they did was on increasing compliance among these 3 kids. So all 3 kids had an intellectual disability. They were focusing on increasing compliance, but all the kids, in addition to having problems with compliance, they had some other behavior problem. In the data for the one kid I'm going to show you, I don't have time to show you all 3, this child had self-injury, aggression, and crying. So the focus was on compliance, but they also measured the occurrence of these other 3 behaviors. Right? So you might be able to see here. This is data for one child. This is one therapist at the top, second therapist at the bottom. The top panel is compliance data here and here, and then the three panels below that are the data for the other behavior problems. Interestingly, when they improved compliance, so you'll see this is baseline, this is, the intervention was fairly complex and I won't get into it, but it just has reinforced compliance here. When they implemented the intervention, compliance went up. Look what happened to the other behavior problems. Look at crying. Crying came down, self-injury, that came down, aggression, that came down, although it was never very high to begin with. But they found that consistently across both therapists, that in baseline, compliance levels were relatively low. When the intervention was implemented, compliance improved, it went up, and the other behavior problems, the co-occurring behavior problems, also went down. So and again, there's actually a number of group studies showing the same thing, or at least showing that compliance at an early age is problematic or is correlated with other severe and frequent behavior problems at a later age. This is showing the same thing, but at the same time, not at a different age, right? So this child, and again there were three of them, but this child was non-compliant to begin with, and then once intervention was implemented, the other behavior problems went down immediately, not later on. So it makes sense that we need to focus on this because for all the reasons I just mentioned, but also because it may prevent future more serious problems with many of the individuals that we work with. I didn't mention before I go much further. I want to say that a lot of people view they talk about non-compliance, and and again that's in the literature. It's been published a lot. That term non-compliance is used. They see that as a behavioral excess, right? So oftentimes when we work with kids with autism, we focus on two things. We either focus on decreasing some behavior that's occurring too much, that is a behavioral excess, or increasing some behavior that's not occurring enough, right? Focusing on that skill deficit. So people talk about noncompliance in terms of a behavioral excess, but noncompliance is not a behavior, right? If you think about it. In other words, it doesn't pass the dead person's test. Some of you may have heard about the dead person's test. It basically says that if a dead person can do it, it's not behavior. Well, I can ask a dead person to roll over, and he or she is not going to roll over, right? Or I can say, don't roll over, and he or she won't roll over. So technically, noncompliance doesn't pass the dead person's test, so it's not a behavior. But it's nevertheless a problem that needs attention and that we focused on. So my point in saying this is it's probably better to think of non-compliance, if we use that term, and maybe compliance, problems with compliance is a better term, but to think of it as a skill deficit as opposed to a behavioral excess. That is, it's a skill that some kids that we work with just don't have yet, right? It's our responsibility, it's our job to teach that skill. Finally, in terms of why compliance is important, many people see it as a foundation skill, right? So those of you who work in EIBI programs probably know, many of you, that one of the first things you teach is compliance, right? I mentioned that I work with our group of kids at the Scott Center. When a child comes in, if he or she is not compliant, if we find that to be an issue, that's one of the first things we target. That and eye contact are typically the two things that we go after first. The reason is that without that skill, progress on when we teach other skills, so all kinds of skills, you name it, receptive identification, imitation, all those things, it's difficult for the child to make progress without a foundation in compliance. So it's sort of this, some people refer to it as, some of you may have heard of a behavioral cusp. There was an article published in JABA by Wayne Fuqua, who talked about this behavioral cusp and defined it as a skill that's so important that once learned, it opens the door for a whole variety of other skills, right? It's a cusp. It enables them to learn all kinds of other things. And compliance is a great example of that. If that's in the child's repertoire, then that then opens up the door to learn all sorts of other things. Another good example of that, by the way, would be something like crawling by a baby, right? When a baby, before an infant has learned to crawl, his or her contact with the world is limited, but once the infant learns to crawl, he or she can then access all kinds of things in the environment, all kinds of stimuli, and that opens up opportunities for learning. But without that, opportunities are limited to interaction with the caregiver, perhaps. So compliance is like that. So in terms of assessment, so I'll move into assessment now, and I'll talk about things that we do at the Scott Center and things that I do independently when I work and do consulting on these problems. There are three things that really you need to focus on when assessing compliance or eventually, seeing a child who is having compliance problems and eventually developing an intervention. The first thing is the individual's listener repertoire, and I'll talk more about that and what I mean by that in a second. The second thing is that you want to assess compliance with whom and to what instructions. That is, again, I'll get to more of that in detail, but you want to know if the child is non-compliant with everything and everyone, or if it's just certain things and certain people, because that's often an issue. And then also, in some cases, it's important to know what the function of the non-compliance is. Okay, so I'm going to hit each of these in more detail. So before intervention, before you develop an intervention to address problems with compliance, it's important to assess the individual's ability to appropriately respond to instructions. So for a lot of the kids that we work with, their language skills are not great, right? Of course, some have good language skills, but others have relatively poor language skills. So if you've got a compliance problem, it could be that the individual that you're working with just doesn't understand, right, so to speak, doesn't understand what you're asking him or her to do, and that could be the root cause, so to speak, the reason for the noncompliance. On the other hand, it could be that this individual understands you perfectly well, and it's the reinforcer or reinforcement, lack of or insufficient reinforcement is what's causing the noncompliance problems. So before you get to the point of doing something about it, the first thing to do is to assess the individual's listener repertoire. That is, how competent they are at understanding what it is you're asking them to do. This could be with an individual instruction or more broadly, and we actually do both. But you've got to make sure that the individual has the skills necessary to comply with what you're asking him or her to do before moving on from there. So in order to do that, we do a couple of things. The first thing is, many of you are probably familiar with Mark Sundberg's VB map. Dr. Sundberg is here at the conference, and I think he gave the keynote talk presentation yesterday, or the opening presentation. He has developed the Verbal Behavior Milestones Assessment and Placement Program. It's used by a lot of early intervention programs, including ours at the Scott Center. Many of you who use this tool know that it's an assessment and curriculum. It doubles as both an assessment tool and a curriculum, right? So the idea is that you assess the child when the child comes in to work with you into the clinic, or you go into the home to work with him or her, or into the school or what have you. You do an initial assessment using the VB map, and you identify the areas that the child is competent, and you identify the areas that the child is deficient on, and you target for skill acquisition the areas that the child is deficient on, right? So you teach, in other words, you teach to the areas that the child hasn't mastered yet. And the tool is broken up into 3 levels. The assessment tool, it was designed to assess all sorts of things like imitation skills, social behavior, other types of play skills, and listener repertoire. So although we do the entire map, for the purposes of this talk and for the purposes of focusing on compliance, we really attend to and focus on the listener responding, it's called, section of the VB map. So as I mentioned, it's broken up into 3 levels, and each of these levels corresponds with skill. So level 3 represents the highest level of skill for that task, in this case, listener responding. Level 2 is sort of the intermediate level, and level 1 is the basic level. So for the listener responding section, that is when you're assessing how well the child can how well the child's behavior is controlled by what you say, right, by the instructions that you deliver. In the first level, you're asking very simple things like, you're assessing very simple things like, does the child orient to the speaker when the speaker says something, right? For some kids, the answer will be no, right? In other words, there's all kinds of, when I'm in a room, there's all kinds of sounds in the room. There's a door opening, there's the air conditioning coming on, and there also might be someone saying something to me. If the child doesn't orient to the sound of speech compared to other things, like the air conditioning coming on or the door opening, then he or she wouldn't pass level 1, right? So you'd score that, and the child would be deficient with respect to listener responding at level 1. If that's the case, then it's pretty likely that the child is non-compliant because he or she doesn't have the adequate listener repertoire to respond to what you're asking him or her to do, right? So it's the most basic level. As I said, you're really just assessing the extent to which the child will orient to sounds. Some of the other things I've listed, this is a snapshot of the level 1 on the instruction sheet. Responds to hearing his or her own name 5 times. So when the therapist says, Johnny, does Johnny turn and orient to the therapist consistently 5 times, yes or no? So, very basic things like that. The second level, so if the child does all those things in level 1, then you go to level 2. In the second level, the listener responding area gets a little bit more complex. You're asking things like, does the child select the correct item from an array of 6 items? So if you say touch car and there's 5 other items out, does the child touch car? Again, the point is to assess the extent to which he or she can respond to a vocal instruction. And if the child passes level 2, then you go to level 3. Level 3 gets a little bit more complex. Many of you may know that the VB map was designed to go up to 48 months. So level 3, you're usually dealing with, if the child has few deficits or is typically developing, you're usually dealing with kids that are maybe 4 years old, 3 to 4 years old. But I'm sure you all have seen this too. We've been dealing with, we work with some kids who are much older than that and of course don't have level 3 or sometimes even level 2 skills. But in level 3, you're asking things like, selects an item by color and shape from an array of 6. You're asking the child to make a conditional discrimination, right? Touch the red car when you have an array of cars. Some of them are yellow, some of them are blue, some of them are red. So if the child passes level 1, level 2, and level 3, that is masters it or scores out of it, then we start suspecting that he or she has the skills necessary to respond to instructions, right? In other words, the listener repertoire isn't so much the problem. But if the child doesn't pass certainly level 1 and even level 2 and sometimes 3, then we often start suspecting that there's an issue there, right? That an issue with the listener repertoire. The child may not have the skills to understand what is being asked of him, and that might be responsible for compliance problems. Even with that, though, so let's say a child comes in, and we see a lot of kids like this who pass level 1, pass level 2, and don't completely pass level 3, but can do some of the things that are asked in that level. Even then, it still could be the case that the specific instructions that are being delivered by parents or teacher or what have you, the child still may not understand them, right? In other words, there's a problem with stimulus control, that the instructions that are being delivered aren't controlling the appropriate responses on the part of the child, even if they can pass maybe level 1 and level 2 on the VB map. So in some cases, if we suspect that, we'll actually formally assess that. We'll directly assess whether or not the child can understand the instructions that are being delivered. And so I'm going to show you some data, an example of that, show you some data from that in a second here. The reason, it's important to do this is that if you find that the listener repertoire is problematic, that suggests one intervention. If the listener repertoire is intact, not a problem, that suggests another intervention, right? So they're separate things, separate interventions that should take place depending upon whether or not the listener repertoire is adequate or not. So we've been doing this, but recently published a study in which we assessed the individuals we had 6 kids, and we assessed their listener repertoire, and then based on whether or not the repertoire was adequate or not adequate, we developed an intervention. So I'm going to take you through that and show you data from 2 kids. So the assessment involves, and again, this is after the VB map is done, it involves 3 phases. An antecedent control assessment, that's what we call the first phase. A functional analysis, if that's necessary, that's the second phase. In some cases it's not, and I'll tell you when it is and when it isn't in a second here. And then a treatment evaluation. So for the antecedent control assessment, the first phase, we wanted to, one of the instructions, and this wasn't the only instructions that the kids were having problems with, but one of the instructions was give me the toy, right? So very simple, basic instruction, and the child was not compliant with that instruction. We didn't know if the reason for compliance was that the child did not understand what was being asked, or if he understood, but the motivation to maintain access to the toy was too great, and so we saw 0 compliance. So we wanted to assess whether or not the child understood that phrase first. So in the first part of what we're calling this antecedent control assessment, we assessed whether or not the child could adequately tact items that we used in the instruction. So I said earlier, give me the toy, but we were when mom and teachers delivered the instruction, it was actually give me the blank, whatever the child had access to at the time. It wasn't a generic name like a toy. It was iPad or car or what have you. So we in the first part of this assessment we assessed whether or not the child could adequately receptively identify or tact. It was really a kind of a tact intraverbal skill, items that were in an array. Then in the second part, we identified whether or not the child could adequately respond to the verb that was used in the instruction. Right? So in any instruction, there's a noun and a verb, and the verb phrase or the verb clause, in this case, give me, was assessed in the second part. And in the first part, the item that was the subject of the verb phrase was the toy or the iPad or what have you, was assessed in that first part. So we have 4 panels here. I'm going to show you data for 2 kids. The first one is Carter. So we'll start with the top panel here. There were 6 items assessed. It may be hard to see the names of those items, but they're all various toys. So we did a stimulus preference assessment first with these 6 items. These were identified by parents as being either highly preferred or not highly preferred. The not highly preferred item for Carter was a book, and the highly preferred item for Carter was an iPhone, that he played games on. So he used the iPhone to play games, and that came out number 1 in the preference assessment. The book came out last, so it was not preferred. So in the first phase, we simply asked Carter to receptively identify all 6 items. The therapist said, touch book, touch phone, touch whatever, the other 4 items that were in there. And you can see that Carter did well. He could identify all those items. So that tells us that his listener repertoire with respect to the noun wasn't problematic, right? He could identify all those items when asked to do so. Then we went to I'll direct you to the bottom panel here. We took the highly preferred item, which in this case was the phone that he played games on, and we used 3 verb phrases. So give me, bring me, pass me. We identified these beforehand. Parents used give me, teacher used bring me, and he had he also went to a daycare, and occasionally they said that they would tell the kids to pass me things because they were in a line. So we identified these 3 phrases that essentially meant the same thing, right? The same action is required on the part of the child, but the words that are used are slightly different, right? So we identified these 3 verb phrases to see if he would comply with, when we used any of them, when we asked him to hand over his most preferred item, which in this case was the phone. And he did not. As you can see, in all of our sessions, he never complied. Each session includes 5 trials, so he had a number of trials across those 3 sessions, with each of those phrases, and he never complied. So that's telling us that either he doesn't understand, so to speak, those phrases, give me, pass me, bring me, or he does understand those, but the motivation to maintain access to the toy is too high, right? We don't know which. So I'll direct you to the third panel up here. In the third panel, we had the same phrases, give me, bring me, and pass me the toy, but in this case it was the book instead of the iPhone. So remember, the book was his least preferred item. And we did get some compliance there. So if he'll comply at least some of the time when we ask him to do those things with a non-preferred item, but won't comply with a preferred item, what does that suggest? Yeah, it suggests that the motivation to maintain access to the toy is high, and so it's not an issue with his listener repertoire, right? It's a reinforcement issue. And then finally, just to verify that that was the case, we asked him to give up the item, in this case the book again, but we had a preferred edible item that we delivered contingent upon compliance. And he complied in every trial, across all three phrases. He complied with that. So the conclusion there is that it's not, for him at least, it's not a problem with his listener repertoire, it's a problem with insufficient reinforcement, right? For that type of instruction. Now you could do this with other instructions as well. This is just one example. But it pretty conclusively identifies that the listener repertoire is okay, and then we move over to this other problem, and that's the insufficient motivation or insufficient reinforcement that's in place to increase compliance. Okay, so here's Carter's treatment. That was remember I said this includes three phases: the antecedent control phase, where we identify whether or not there's a problem with the listener repertoire, and then if there's not, then we go to a functional analysis. So that's in the top panel here. We did what some people call a pairwise functional analysis, just two conditions. A tangible condition where he has access to the phone, and the therapist says, give me the phone, and if he doesn't comply, he maintains access to the phone, and so the function, when compared to a control condition, if compliance is low, that suggests that the motivation, the function of the noncompliance is to continue to maintain access to that preferred item, that phone. And that was the case for him. And then this is an intervention that we evaluated, in which DRA stands for difference reinforcement of alternative behavior. So Carter got access to extra time with the phone contingent upon handing over the phone when the teacher requested, right? So if he complied with the teacher's request, then he got an extra period of time, an extra long time with the phone at some later time, and we use tokens to give him access to that. And I'll get into interventions later, but as you can see, it was pretty effective. 0 rates of compliance in baseline, and then high levels of compliance in intervention. Now, the second participant that I'll talk about, Wendy, was a bit different. We did the same thing, except we used only 4 items with Wendy. She liked puzzles, and she preferred a puzzle that had the number 1 and the number 2. That's the one that she used most often. And she also had an iPad that she used. So we did a preference assessment with 4 items, the 2 puzzle pieces, an iPad, and some toy glasses that she used. And found that the puzzle piece was the lowest preferred. I think puzzle piece number 1 was lowest preferred, and the iPad was the most preferred. So in the first panel here, we're just asking her to receptively identify those 4 items. And you can see that for the puzzle piece, the 2 puzzle pieces, she could, but for the other items, the tablet, which was the iPad, and the glasses, she could not. Right? So that suggests that her listener repertoire is it's good for some items, but it's not for others. Then we, again, the instruction for her was give me, bring me, or pass me. In this case, it was the tablet, which was the most preferred item, and no compliance or very little compliance. So that suggests that either she was motivated to maintain access to the preferred item, the tablet, or she didn't understand the instruction, right? She didn't understand give me, bring me, pass me. We went up in this panel. We used the lowest preferred item, which was the puzzle piece, and we asked her to give me, bring me, or pass me the puzzle piece, and she, for the most part, did not do that. There was a little bit of compliance here, but she didn't do it here. We know that she understands, that is, she can receptively identify at least those puzzle piece items, but she did not give them when the therapist requested over all these trials. So that suggests that again, there's either a motivational issue or she's not understanding the instructions. So the last panel, we did the same thing here, but we delivered highly preferred edible item contingent on compliance. So, thinking that would, if she complied, that would mean that the motivation to comply with the instruction was not a problem, that it was a listener repertoire issue, and she did not comply. We also did, by the way, a preference assessment between the edible item and the puzzle piece to make sure that the edible item was more preferred, and it was. So, in other words, she should have complied here if she knew what we were asking her to do. So the conclusion from this is that she does not understand, her listener repertoire is not good for her preferred item, that is the tablet in glasses here, and it's also not good for the 3 verb phrases we were using, give me, bring me, pass me, right? Her intervention data is presented next, and for her it makes sense to do 2 interventions, right? Because the first part of the assessment told us that her receptive identification skills are not such that she can tact or identify items well, so we have to teach that first, and then we have to teach her to appropriately respond to the verb phrases we were using. So in the first intervention, we were teaching her to tact tablet, which was her most preferred item, and we used just prompting and reinforcement to do that, so we used a prompt delay procedure. And to teach her to identify the tablet, and it was effective. We had glasses as a control condition, so we didn't use prompting and reinforcement for the glasses. And then in the next intervention phase, we taught her to respond appropriately to the 3 instructional phrases, verb phrases we were using, give me, bring me, pass me. So we used a multiple baseline design, and you can see that she only complied once the intervention was implemented for each of the verb phrases. Interestingly, they didn't generalize, right? In other words, once we taught one verb phrase, even though we're really just varying one word in that phrase, she didn't comply with the others until we explicitly taught the other phrases, right? Which actually we see this a lot with kids, is that you might suspect that things as simple as bring, give, or pass, because words that are very similar, that mean the same thing, that are just slightly different, that you would see some generalization across those, but oftentimes we don't, and we did not with her. Anyway, the whole purpose of that, again, is to make sure that the child's listener repertoire is intact, and assess that first to be sure it's not responsible for the compliance problems. Because in Wendy's case it was, and in Carter's case it was not. So I just wanted to show you an example of each. The second area of assessment for compliance is this. You need to assess compliance to what and with whom. So as I mentioned earlier, a lot of kids are compliant to one person or with certain instructions but not others, or in certain contexts, say school but not at home, or vice versa. So there needs to be some assessment of the conditions under which the child does comply with various instructions delivered by various people. This is an example of a data set in which we did that. It's really just descriptive data in which we evaluated the percentage of instructions in which the child complied, and that was about, you can see the blue bar is about 50 here. So in other words, this was at home. We followed the child around, the therapist followed the child around at home for a couple of hours, and every time an adult, mom, dad, or sister delivered an instruction, we recorded it, and we recorded whether or not the child complied. So only about half the time did he comply in this example here. Then we separated that by adult, or the individual that was delivering the instruction, and you can see that with dad, he complied much more often, right, than with mom and with sister. And then we separated that, again, by type of instruction. And the 2 most common were come here and put something away. Either put toys away or put clothes away in this case. And you can see that there wasn't a whole lot of difference there. He didn't comply with either of them very much. But the interesting part here, I think, is this, that with one person in particular, mom, it's very low. And with dad, it's very high, and sister somewhere in the middle. So we often see that too, that in most cases it is dad for whatever reason. Dad's got some stimulus control that mom or teacher or someone else just doesn't have, and so we see greater compliance with one person than another. There's been some formal assessments for this. So in terms of how to do this, a good model is this study by Stevenson and Greg Hanley that was published in JABA a few years ago. They came up with a formal way of assessing how often a child complies and to whom and to what instructions. And these are the instructions that they used. This is all in the study, in the article, if you're interested. But they had, these were mainly a variety of different categories: gross motor, fine motor, self-help, and they had specific instructions within each category. And they had the items that they used, and they had the therapist deliver each instruction to each child to assess whether or not he complied with each one. And their data look like this. Actually had a lot of kids, I think 30 kids in total. And they, when they were done with all those instructions, done delivering them, they simply graphed them. And each of these panels represents a child. Interestingly, they suggested two compliance criteria. One was a 6-second criteria, and the other was a 30-second criteria. So remember at the beginning of the talk, I said that even though 10 seconds is often used as the appropriate amount of time that you want to give a child to comply, their data, if you look at their data closely, you'll see that there's a lot more compliance with many kids to the 30-second criteria, which is the filled triangles, than to the 6-second, which is the open triangles. Right? And not for every kid, but with a lot of kids, there's a clear difference between the 30 and the 6, which suggests that the amount of time that you give a child, especially a child with a disability, may be important. In other words, maybe parents and teachers just aren't allowing the child enough time to comply with the instruction. But anyway, the point of me showing you this is just that there's a formal assessment out there, if you're interested in doing it, that's already been evaluated, and you can just take that and use it. When you're delivering these instructions, though, and again, this is in that article, when you're assessing these, you've got to make sure that you do a number of these things. One, give direct instructions instead of indirect. In other words, do this instead of, why don't you do this right now, right? So there's a big difference between direct and indirect instructions. There's a lot of research showing that direct is more effective. Provide a specific amount of time for the child to respond. Again, they used two criteria, 6 and 30, and they got much more compliance with 30 for many kids. Don't complete the instruction for the child. That seems obvious, but sometimes parents, well-meaning parents and teachers may assist in some way, and if you do that, then you're not really assessing whether or not the child can do the task or comply with the task independently. And be sure to vary the order of instructions. So the instructions shouldn't be all in the same order, because some kids may learn that when I hear things in this order, I comply with the last 3. When I hear things in a different order, I don't, that sort of thing. If assessing across caregivers, make sure to have each caregiver deliver the same set of instructions, right? Because as we saw earlier in that example that I showed you with mom and dad, it could be that a child is much more compliant with some instructions delivered by mom and much less compliant with some instructions delivered by dad. So you want to make sure that you've got an equal number of instructions delivered by the same person. Yeah.
Do you repeat the instructions if you're waiting for a child, say, for 30 seconds? Might you repeat the instructions 1 or 2 times?
Good question. Yeah, the question was, would you repeat the instruction if let's say you're waiting for maybe 30 seconds for the child to comply? Once you've delivered the instruction, would you then again repeat it once or twice before the end of the 30 seconds? And the answer is no. And for purposes of this assessment, you wouldn't. You just deliver it once and then assess it. Okay, so far in terms of assessment, we've talked about first assessing the child's listener repertoire, and the second thing we've talked about is assessing compliance to what, with whom, and how often compliance does and doesn't occur, the conditions under which it occurs. The third thing to assess, at least in some cases, is the function of the compliance problem. Right, so now this won't be necessary if the root cause, so to speak, of the problem is the individual doesn't have an adequate listener repertoire. Right, so remember the data I showed you earlier with Wendy and Carter. For Carter, his listener repertoire was good. He could understand what he was being asked to do. The problem was with the reinforcement surrounding the compliance. It was insufficient, or there was some other problem with it because he wasn't complying. But he understood what he was being asked to do. So for those types of kids, assessing the function of noncompliance is important. For the kids that have a problematic listener repertoire, this step's not necessary because the intervention then focuses on teaching the child to respond to the specific phrases used in the instruction, the nouns and the verb phrase and et cetera. So, but a functional analysis may be necessary for those kids who do have an adequate listener repertoire. And if you think about it, unlike I think a lot of other behavioral excesses that we deal with, for example, self-injury, maybe property destruction, all compliance problems are socially maintained, right? So when you talk about self-injury in other behavioral excesses, they can either be maintained by social consequences or automatic consequences, right? So in other words, the reinforcer that they're obtaining by engaging in the behavior may be independent of other people, right? I may flap my hands in front of my face because I like the way it looks, or I like the way it sounds when I do it next to my ear. And that's independent of anyone else, right? So it's automatically maintained. Well, compliance is not like that. I can't think of a situation in which you would have a problem with compliance that's maintained by automatic reinforcement, right? It's all social. There's two reasons why kids aren't compliant if their listener repertoire is intact, and that is it either gets them something they want or it enables them to avoid something that they don't want, avoid or escape something they don't want. So it's either maintained by social positive reinforcement or social negative reinforcement. There's really, you're not dealing with that automatic group, that component over there, which is good in a way, right? So it kind of narrows down things. So there are a number of models for functional assessment or functional analysis of compliance problems that exist. I've listed the four that are kind of used and cited most often. I've talked a little bit about the Stevenson and Hanley article already, and that was more of a descriptive assessment, not a functional analysis, not an experimental analysis. The other three were experimental, and I'll talk a little bit about those now. The one I want to highlight was, this was published a few years ago by Rachel Thompson and her group. They had 3 kids, and unfortunately, they, like a lot of studies, and I'm guilty of this too, really up until recently, no one has first assessed listener repertoire, right? When a child is presented as noncompliance, they immediately go into a functional analysis, assuming that the problem is with reinforcement. But it could be that, for some of these kids that in many of these studies that have been published, the problem was with the listener repertoire first. So, that step has kind of been ignored. That's why I emphasized that earlier, that it's an important step. So they didn't do anything regarding listener repertoire, but they had 3 kids, all of whom had a disability and who were noncompliant, and they had 2 conditions that they assessed. One was an attention condition. I think many of you know about the 8294 Iwata functional analysis model, those conditions that exist in that model. They only employed 2 conditions, not all that are typically employed. And the reason is they didn't need many of the others. Right? So they had an attention condition and an escape condition. So the idea was that, each of these children could be noncompliant. They may not be compliant with instructions, because when they are non-compliant, they get a lot of attention from the parent or teacher, right? So you all have probably seen this. I've certainly seen this many times where, Mike is asked to do something by mom, and Mike doesn't do it, and then mom says it again. Or mom, goes over and touches Mike, or touches Mike and says it again, right? So there's a lot of attention that's delivered, well-meaning attention, but it's a lot of attention that's delivered contingent upon noncompliance. And in some cases, it could be that the noncompliance is maintained by all this interaction and attention from the parent or teacher, whomever. And the other condition was escape condition. This is the condition that I suspect most people would think would be responsible for compliance problems, right? So, when you're asked why doesn't Mark do what you ask him to do, most people would probably say, well, he probably just doesn't want to do it, right? He'd prefer to do something else. In other words, he's trying to avoid or escape the task that I'm asking him to do. So I think a lot of people would suspect that much of noncompliance is maintained by social negative reinforcement. So they had, again, assessed these 3 kids with just these 2 conditions, and kind of surprisingly found that for all 3, attention was the maintaining variable. That for 2 of them, escape didn't appear to be important at all. For this child, the bottom child, escape may have been playing a role, but attention was appeared to be the most important, because it's the data path is higher than the most important variable maintaining noncompliance. So it was interesting in that it's a model for assessing the function of noncompliance using a fairly quick and simple procedure with just 2 conditions. And the results, they found that attention, somewhat surprisingly, was most important, at least for these 3 participants. So in an F, I'm going to show you some FA conditions here in a second for noncompliance. It's a bit, when this is done for this behavior problem, it looks a bit different than when it's done for other behavior problems. So I've got some short clips to show you. So when doing this, as you probably know, the purpose is to identify the variables maintaining noncompliance. In other words, why are they doing it, right? Are they doing it to get access to something, or are they doing it to avoid or escape something else? It consists of typically just a test, sometimes more than one test condition and a control condition. And conditions with the elevated level suggest that that condition or that variable is responsible for maintenance. So the test condition for positive reinforcement is the attention condition. This is the same thing that Rodriguez and Rachel Thompson used in their study. In this condition, I'll show you a video clip in a minute, but it's pretty straightforward. The therapist presents an instruction to the child. If the child complies, the therapist delivers no attention, no physical touch, no vocal interaction. If the therapist does not comply, then there's lots of physical touch, there's lots of vocal interaction, right? So the idea is that if you repeat that over and over across trials, and by the way, these are all done on a trial-by-trial basis. So it's not, in the typical FA, you're probably thinking of a 10-minute condition, and you're looking at the rate of behavior during that 10 minutes. This is a bit different in that you're looking at whether or not compliance occurs on a trial-by-trial basis. So each trial is one presentation of the instruction, and you assess, does compliance occur or no, yes or no? All right, so over time, over trials, if noncompliance is met with physical and verbal interaction, the idea is that that's probably what's maintaining the noncompliance, right? If it's high, if it occurs more often in that condition compared to the others. So I'll show you a quick example here. To do so, I have to exit the PowerPoint. My link wasn't working. So in that condition, the therapist asks the child to put the paper in the trash, right? So just as an example of an FA condition, there are 3 pieces of paper, and he complied. Because he complied, that was the attention condition. She didn't do anything, right? No program consequence. Okay, so I'll show you the same condition, but when the child doesn't comply. Right, so you see that in the first condition, compliance resulted in no program consequence. In the second, the therapist provided a lot of physical interaction, a lot of vocal interaction. And again, if you run that over and over, right, and you have a number of trials, and you're looking at the trials in each in which the child is not compliant, if it's maintained by that attention, you should see higher levels in that condition relative to some of the others.
How far apart
Yeah, good question. I think, when we're doing this for clinical purposes, that is when we have a child come into the clinic, we do it across, usually we can get done in a full day, but a full day is about 7 hours. If you're doing it for research, oftentimes it's, we have to kind of condense it and do it for much less. So in the test for negative reinforcement, the escape condition, so remember in the Rod Thompson data I showed you, there was an attention condition. They contrasted it with an escape condition. In this condition, compliance equals verbal and physical interaction, and noncompliance, the task is removed. So if the child complies with the instruction, the same instruction is delivered. If the child complies, then they get verbal and physical interaction, or perhaps just a thank you and a pat on the back. In other words, there's maybe some attention, but not a lot, but some acknowledgement that there's compliance. And then noncompliance, they don't have to do the task, right? So again, over trials, if the noncompliance is maintained by avoidance or escape from the task, you should see higher levels in this escape condition. So again, I'll show you a quick example. Right, so you may not have seen there, but although he complied with the instruction by putting one piece of paper, remember there are three, there's always three, and he knows that. So he put one in, didn't put the others in. She had to put the other two in, but he didn't have to do anything else, right? In other words, he escaped from having to do anything else. So when you run those conditions back and forth, you can often see the contrast, and whichever one's higher, that's suggestive of that function. Then you have a target for intervention, right? If the noncompliance is maintained by attention, that suggests one intervention, which, again, I'll get to after the break. If it's maintained by escape, that suggests another avenue, which I'll talk about later as well. It's also possible that an individual may behave in a noncompliant way to maintain access to a preferred item, right? And this, again, although I think most people would say, well, it's probably because he doesn't want to do the task, right, to avoid or escape it. In many cases, there's a preferred item involved. So if that's the case, if there is a preferred item involved, it's good to have another condition. So a materials condition is often called a tangible condition, right, where the child maintains access to the item contingent upon noncompliance. So in this condition, the child has a preferred item, and the therapist says, give me the whatever, and if the child complies, there's no program consequence. If the child doesn't comply, the consequence is that he or she retains access to the item. And so, again, over time, you should be able to see higher levels if the function is to maintain access to an item. So here's just a quick example. Now, we cut the video off too soon there. He went around the table and he continued to play with the toy, right? So he didn't, in that, for purposes of what we were doing there, complying was defined as handing her the toy. You couldn't throw it at her or swipe it across the table. You had to hand it to her. So he kind of threw the toy and then went around the table and quickly continued to play with it, right? So again, over a number of trials, if you deliver that instruction, you see elevated rates in that condition. That suggests that the purpose, the function of not complying is to maintain access to the toy. You should also, when we're assessing noncompliance that might be maintained by access to a preferred item, we also use a control condition, right? Because you want to have some condition to compare that to. So let's say we get high rates in that materials condition where he consistently is noncompliant, maintains access to the toy. But what do you compare that to? Well, a control condition is used, and the control condition is fairly simple. We put a preferred toy, we don't give the child a preferred toy, but we put it at some distance from him or her and just ask him to go get it, right? So he doesn't have it, but we say, go get the toy. And if the child complies with that instruction, then in almost every case he or she does, then you're going to see high levels of compliance in that condition. And if the noncompliance is maintained by access to toys, you're going to see much lower levels of compliance in the materials condition. And I won't go through an example of that because it's very simple. The therapist just says, there's a toy on the table, the therapist just says, go get the toy. And the child just goes to get it, and you record compliance levels with that instruction. Compare that to the other instruction in which the therapist is asking the child to give me the toy. Okay, so those are the three things that we look at when we're conducting assessments, right? So we look at the individual's repertoire, listener repertoire, the conditions under which compliance occurs, and if it's necessary, we do a functional analysis. A lot of times, I've had parents and teachers ask me, well, is it really necessary to do a functional analysis for every case of noncompliance in which the child's listener repertoire is adequate? That is, they understand what you're asking him or her to do, but they're still not compliant. You have to do an FA, a functional analysis, for every case. There's so many, right? There's so many kids who have this behavior problem. That seems like a lot of work for all these kids. And my answer is that we don't do it for every child. For the severe kids, the kids that are just pervasively noncompliant or who have other behavior problems along with the noncompliance, then we do the FA. But for kids who are less severe or for whom noncompliance is less frequent, we don't typically do the FA. We go right into an intervention. And so I'm going to talk about interventions now. Let's see. It's 2:21. We'll take a break in about 10 minutes, but I'll go ahead and start the intervention section. So there's two types of interventions that have been developed. They're categorized by whether or not the procedure that's used to increase compliance happens before the instruction, antecedent-based intervention, or whether or not it happens after the instruction, consequence-based intervention. So I'm going to talk first about the antecedent-based interventions that have been developed. And I've got a list here of interventions for compliance that are supported and those that are either unsupported or have received mixed support. And I'm basing this on the literature, the scientific literature. So we reviewed all the studies, and believe me, there are a lot. I had a PhD student do this, and he was hitting himself over the head because he had to look through 40 years of research on compliance, and there are literally hundreds of studies. So he reviewed them all and came up with a list of those that show some support, that have some support, show some effect, and those that don't. The ones that the antecedent-based interventions that have some support, the first one is, very simply, making eye contact before delivering the instruction. So, in many cases, this is not going to be sufficient to improve compliance, but there have been some studies, more than one study actually, showing that the simple act of the parent or the teacher requiring or making eye contact with the child before delivering the instruction increases the likelihood that the child will comply with the instruction. So one of the things that we always tell teachers when we do teacher training is, first off, make sure that you make eye contact. Get their attention. It could be that they're not attending to you when you're delivering the instructions. So even though making eye contact is no guarantee of attending, at least you know that they're looking at you when you make eye contact and then deliver the instruction. And as I said, surprisingly, that has been shown in some cases to improve compliance. The second one is deliver do instructions as opposed to don't instructions. Right? There's been a few studies showing that parents and teachers who consistently use instructions to do something as opposed to not do something get better compliance. No one knows why. Maybe it's the could be that for some kids there's a stimulus control issue there that they understand do but they don't understand don't, so to speak, or they have a history with do and don't have the same history with don't, or Who knows? It probably varies, but there are some studies suggesting that these do instructions are better. Another intervention that has been shown to be, that has some support, is phrase the instruction as a statement, not a question. Right? So a lot of times parents and teachers will say, can you do this for me? Can you turn the light off? Can you go bring me your toy? Can you clean up your room, right? These types of instructions. So that they're phrased as a question. And there's been a number of studies showing that that instructions that are phrased as a statement as opposed to a question are more effective. This is, for similar reasons, when we're working with kids with autism in early intervention programs, and we ask them to do something, we tell them to do something, we phrase it as a statement, not a question, right? We don't ask them. And the issue there is that you want to establish, especially with learners with disabilities, you want to establish good stimulus control early. When I tell you to do something, that means that you need to do it. When I ask you to do something, I'm giving you the option. But if you phrase an instruction as a question, you're mixing the two, right? Which can be confusing, especially to kids with disabilities. So be consistent in terms of what you want out of the instruction. If the child is required to do this, don't phrase it as a question. Another antecedent-based intervention that has some support is the high-P sequence, high probability sequence. And I've labeled this as an antecedent-based intervention, although it has some consequent-based components, and I'll talk about that later. But many of you are probably familiar with the high-P sequence. I've got a video example of it a bit later that I'll show you after the break. But essentially consists of 3 high-probability instructions delivered immediately before the target or low-probability instruction. Right? So it's based on the theory of behavioral momentum. That is that you sort of get compliance moving, and the child is more likely to comply with something that historically he hasn't complied with. And that has some support, although there's some research showing that that's not always effective as well. And then the last one here is antecedent intervention that has some support is decrease the effort associated with the instruction. Right, so a lot of times, without even thinking about it, parents and teachers, caregivers, they're asking a child who may have a history of problems with compliance to do something that's pretty complex, that may be multi-step, or that may involve, a lot of effort, a lot of physical effort, walking down, across the house or across the room to get something or to put something up, something that's fairly effortful. And there's been some research showing that, for some kids at least, if you start with low effort instructions and then sort of work your way up the effort ladder, then you get better compliance. There's also some unsupported antecedent-based interventions or that have received mixed support. The first one is providing free access to a preferred item before you deliver the instruction. So in other words, if I know that Mark likes cars, and I know he has a history of being non-compliant, before I ask him to do something, I'm going to give him access to his cars and then present the instruction. And so there's been a number of studies that evaluated that procedure. Sometimes it's been effective, but other times it hasn't. And really the bulk of the research is showing that it's not very effective. Another one is providing advance notice of an upcoming instruction, right? So some of you might have heard of this. The idea is that you provide some advance notice, maybe a minute, 30 seconds before an instruction is delivered, and then compliance is more likely to occur because of that advance notice. So I might say, Mark, in 1 minute, we're going to have to clean up. 30 seconds later, Mark, in 30 seconds, we're going to have to clean up. 30 seconds later, Mark, clean up. Right? So there's been some studies evaluating that procedure. It's got some mixed support. Some studies show it works. Others show it doesn't. Probably depends on the individual. The last one that has mixed support is providing a rationale. Right? So a lot of times parents and teachers, caregivers will provide a reason as to why the child should comply right before, either before or after delivering the instruction. So Dad'll be home soon. Clean up your room. Those sorts of things. Those sorts of reasons or rationales for why compliance should occur. And of course, they're only likely to work with individuals who have good language skills. But even with those individuals, there's been some mixed support on that, and I'll talk a little bit about that too. Okay, it's 2:30, so I'm going to go ahead and take a break, and then I'll hit these after the break. So let's take a 15-minute rest. So I'm going to start up again, continue. So just to refresh you, we're talking about interventions, and earlier in the talk we reviewed why it's important to focus on compliance, and we talked about assessment of compliance. Now we're on to intervention, and I said there are two broad categories of interventions for compliance problems. Is that better?
There you go.
Okay. Helps to turn the mic on, huh? So earlier we talked about why compliance, why it's important to address compliance. We also talked about assessment, and then we started on interventions. We talked about two broad types of interventions, antecedent-based and consequence-based. And we're in the midst of talking about antecedent-based interventions now. So I'm focusing on a few of the interventions that have either full support or mixed support in the research literature. The first one I want to talk about is advance notice. So I mentioned it earlier. This just involves providing a warning or some kind of advance notice of an upcoming transition and to the child or the individual. So there was one study published in 1995 in which this was effective. The focus was a man, an adult man with autism, and they were having problems with compliance and making transitions from one setting to another. And the authors of the study used advance notice of an upcoming transition, and it was effective to increase compliance with moving from one task to another task. More recent studies, though, have not shown as much support. And I'll show you a quick example. It's easy sort of to comprehend what advance notice is, but picture's worth 1,000 words.
And in 1 minute, I'm going to ask you to give me the toy, okay? Then, in 30 seconds, I'm going to ask you to give me the toy.
Okay, and then in 30 seconds later, she said, "Give me the toy," and he complied. So it's very simple, it's just giving you the advance notice. We use a minute and 30 seconds in this example. Oftentimes, when it's used in practice, and I've seen it used in the literature, they'll use like 5 minutes, 2 minutes, 1 minute. Right, so the amount of time for the advance notice may vary, but in general, the procedure is the same. By the way, this is recommended in a lot of parenting books. Some of you may have read about it. There's a well-known parenting book by Rex Forehand, who is a clinical psychologist who I believe is now retired. He did a lot of research on compliance when he was at the University of Georgia for a while, back in the 80s and 90s. And advance notice is one of the things that he recommends. Yes?
Would this be the same thing as giving them a visual timer as a countdown, or is that different if they're in a
Good question. It's similar to that, but the difference is that when you give advance notice vocally, it's the stimulus, the vocal stimulus is there, but then it's gone, right? And so you asked if you have a timer or some other sort of visual stimulus. There's all kinds of items that are sold nowadays that provide some visual cue as to when some transition or some notice of some instruction that will be delivered is upcoming. Clocks or that move, that are one color at a certain time, and that at some point change to green, from red to green, something. All sorts of things. The time tracker we use at the Scott Center. That's a specific. So those are similar to this, but a little bit different in that they're always present. And for kids with disabilities, those are probably more effective. And there's not as much research, actually, kind of surprisingly, on that as opposed to something like this. But those, because they're not present and then absent, there and then gone, those are probably more effective. And we actually use a lot of visual timers with our kids. But this is a little bit different, and it's just the instruction. Anyway, I was saying that there was Rex Forehand, who did a lot of research with this on this intervention for compliance in the 80s and 90s, recommended it in a book. The book is titled The Non-Compliant Child. It's a self-help book, but it sold millions of copies. Was targeted at parents of kids with disabilities as well as parents of typically developing kids. And in one of his chapters, he's got a chapter on antecedent interventions, and he recommends the use of advance notice. But at the time, there wasn't a whole lot of research on it. There's more now. And not that it never works, but there hasn't been a whole lot of studies showing that it does work. I think something like the always present visual stimulus, visual cue, is probably more effective than something like this. Here's some data from a study evaluating advance notice. It's hard for me to see at this angle, but the AN, or in the top panel, it says advance notice, and then it says AN. That's the advance notice phase. The filled circles is compliance, and then the open triangles is problem behavior. So we measured both compliance as well as other problem behavior like self-injury, aggression, and the child just vocally protesting, no, leave me alone, things like that. We lump all those together as problem behavior. But what you should mainly be interested in is the filled circles and whether or not compliance is high in that advance notice condition. And as you can see, it's not. It's it improved a little bit in the first advance notice condition, but then went down. We actually had to implement another intervention, physical guidance, essentially a guided compliance procedure, which I'll talk about later. And that was effective over here, and here with the first child. Same thing with the other two. The advance notice just didn't do much. Oftentimes there was an immediate effect. There might have been an increase in compliance initially, but then it went down and didn't maintain. And in some cases, we found something interesting here. This was published in JAMA, I think, 3 years ago. In this last child in particular, remember I said the open triangles were problem behavior. We actually got an increase in problem behavior when we used advance notice. So in other words, the therapist would say, all right, in 1 minute you're going to have to do this. In 30 seconds you're going to have to do this. What this child in particular started doing is once the therapist said that, the child would say, well, no, I'm not. I don't want to do that. And then that would evoke more, he would sort of get riled up, and that would evoke more problems. So it didn't work at all. It wasn't a good procedure. And again, that's not necessarily the case with every individual. It may work with some. As I mentioned, there has been one study showing that it did work, but certainly not across the board, certainly not effective across the board. Another antecedent-based intervention that I mentioned is the rationales. Again, the book that I mentioned earlier, the self-help book called The Non-Compliant Child, he also has a chapter, Forehand has a chapter on this as well, and recommends delivering these rationales before delivering an instruction. The idea is that, if the child understands, knows the reason that he or she should comply, that they're going to be more likely to comply. And that's... although, again, that may be the case with some kids, the research so far on this, and this is more recent research before Forehand published that book, more recent research shows that that's not the case. I've got an example of it here, but before I show you an example, I'll show you some of the data evaluating it. This was a study in which we had 3 kids. And the RAT condition, the second condition for the first panel there for Becky, that's rationales. We just abbreviated rationales, RAT. So compliance is, sessions are on the x-axis, and this is compliance that we're looking at, percentage of trials with compliance. Baseline, no compliance. We implemented the rationales condition, and all these kids had disabilities, autism, but had good language skills. So it wouldn't make sense to implement this for a kid whose language skills were poor, but for all these participants, their language skills were quite good. So they could understand and they were at least able to comply with instructions. So it might make sense to deliver some reason why the child should comply to get compliance up, but did not work with any of these three. You can see here we had to implement another intervention, contingent access, which is essentially differential reinforcement, to get compliance up. We reversed back to the rationale condition and nothing, and that was really the case for all three. One of the kids we had to use a response cost procedure, actually, in the middle child here, but the point is the rationale intervention just wasn't effective. Here's an example.
It's time to go back to class. Give me your toy. Madam, it's good to share. Give me your toy. Madam, you should do what adults say. Give me your toy.
Yeah, just as an example of the types of rationales that are sometimes used, it's good to share. It's time to go back to class. So, again, any reason why the child might comply or should be more likely to comply might be used as a rationale. But there's been 2 studies so far specifically looking at rationales in the past 5 years. Neither study has shown any effectiveness of the procedure. Again, doesn't mean it won't work with some kids, but for the most part, it at least hasn't been shown to work in research. One of the things that everyone should keep in mind, and many of you probably know this, but when you're looking at evaluating data from single case studies, which these are single case designs, you've got to be careful about making generalizations to larger populations. So it doesn't make sense to say, based on 2 studies with 3 participants, that this procedure just doesn't work. It's ineffective, right? Because that's only 6 participants. Until we have a larger number of studies all showing the same thing, really you need to reserve judgment. But so far, it doesn't appear that this, with the studies that have been done on it, doesn't appear that it's very effective. Someone have a question?
Didn't it seem like a strange rationale that it's time to go to class, but then it's not time to go to class, so it's a made-up rationale?
Yeah, that was just an example in this case. But yeah, I mean, if you were doing this, to really increase compliance with the child, then you'd want it to be something that's not made up, that's realistic. But she was just doing that to show an example of what it might look like.
And why'd she give it back to him after he gave it to her the first time?
Because we were doing these in a short period of time and we had to film it, we treated each one as a trial. So each time she said, give me the phone, that was considered a trial, and then she waited just a few seconds, then delivered the next one. But yeah, if you were doing this clinically, you wouldn't have such a short period of time between them. Okay, let's see. These are the data I showed you. These are data from the same study, except these are data on problem behavior. The previous slide was compliance, and I said that compliance did not improve with the rationales. Problem behavior data were graphed separately, and so problem behavior data, again, are things like complaining or vocally protesting or maybe aggression. We combined all those things and called them problem behavior. I wanted to show you this because, like the advanced notice, with some kids, we actually got an increase. If you look at the bottom here with Andy, We actually got an increase in problem behavior when the rationales were delivered. And again, it was the same sort of thing with advance notice. The therapist would say, do this because X, and give the reason, and then the child would say, well, I don't like that reason, or I don't want to do it because of that reason, or that doesn't make sense, or it would start some confrontation. So just by giving that additional reason, it would start additional confrontation, and it didn't. And again, that's not going to be the case with everyone, but for some kids, that may happen. You may get it may make things worse because of that. Another antecedent-based intervention that's been looked at, as I mentioned earlier, is a reduction in effort. So this one has a little more support than the previous two. The idea here, as I mentioned, is in many cases, parents, teachers will ask a child to do something that involves either multiple steps or a lot of physical effort, and they may, not get compliance. And so if that's the case, and you're trying to increase compliance, it makes sense to come up with sort of a task analysis of what it is you're asking, or the many things you're asking a child to do, and prioritize them, or arrange a hierarchy such that you ask the really simple things, the things that require the least amount of effort first, and then once you obtain compliance with that, move on up, right? Move to the next one and then the next one and so on. And so there's been some work looking at that. This was a study that's in Behavioral Interventions in 2013. Behavioral Interventions is a journal, by the way, you can access. And we were looking at response effort on compliance in young kids. I'll show you data from 3 kids. The first one here, Anna. We were asking all the kids to put away their toys in a toy bin. So this is in a classroom setting, and we were asking them the task. With all these studies, by the way, when you're doing this for research, you have to keep the task consistent. In the real world, of course, you're probably asking many different things, many different instructions. But for research, you have to keep the task consistent, because it could be that you get more compliance with one task versus another, and then that's responsible for the increase in compliance, as opposed to the intervention that you're trying to evaluate. So you have to keep everything constant. So with all these kids, we were asking them to put their toys away in a toy bin, and we simply, and all 3 kids had problems with compliance, teacher reported and we observed, and we simply manipulated the proximity of the toy bin to the child's location, right? And initially it was across the classroom, so about 25, 30 feet, and then when we started the study, we evaluated a number of different locations, but essentially the 2 contrasting locations were a 1 foot, where the child just had to, not move at all, hardly, just to put their toy away, and a 10-foot distance, where the child had to walk 10 feet to the toy bin and put the toy away. And we got, just to see if that made any difference at all, that increase or decrease in effort. And so the first condition is first condition is 1 foot condition, and compliance is the filled circles. You can see we got compliance with 1 foot. Then we moved to 10 and did not, back to 1, got it, back to 10, did not, and then we slowly increased the distance of the toy bin from the child from 1 to 10. So systematically kind of went from 1 to 4 to 7 to 10, and we're able to get, at least with her, we're able to get compliance at the 10-foot level when we did it that way. Here's data from a second kid, similar setup. Compliance was high when the toy bin was close, lower when it was further away, and then we systematically increased it up to 10. With this child, we got to 4, and it's again hard for me to see at this angle, but we went to 4 and compliance went down, so we had to go back to 1 and then sort of make that transition more slowly, go from 1 to 3 to 5 to 7, and we were able to get compliance that way. And then the same thing with this kid. This participant, compliance improved when effort was reduced. So the overall point there is that sometimes you can increase compliance in that way. And this isn't always the case with kids. In some cases, effort has nothing to do with why they aren't doing what you ask them to do. But in some cases, effort may be involved. And if that is the case, you can maybe develop an intervention based on slowly, systematically increasing the amount of effort that's required, and that might be effective. In general, though, so we've talked about antecedent-based interventions, a number of them specifically. In general, antecedent-based interventions are not as effective as consequence-based interventions, right? So not to say that none of them are effective. Some of them may be very effective with individual children, but generally speaking, if you look at the whole literature, antecedent-based interventions tend not to be as effective as consequence-based procedures. So now I'm going to talk about consequence-based interventions. There's been a few of them that have been evaluated. Timeout. I'm not going to focus on that, but timeout just involves, as many of you know, removing the reinforcer from the environment contingent upon in this case, noncompliance occurring, right? So it doesn't necessarily mean removing the child, although it could, but it means removing reinforcement from the environment contingent upon the noncompliance occurring. There was one study that used timeout to increase compliance done by Ray Miltenberger and one of his students in the 90s, and it showed that timeout was effective. You have to be very careful about using timeout for this behavior, though. Anybody know why? Yeah, I mean, we were saying earlier that most kids, or at least you might suspect that a lot of kids engage in noncompliance to avoid or escape something. And if you're delivering, especially if you're removing them from the environment, you're essentially giving them the opportunity to avoid or escape whatever it is you're asking them to do. So you've got to be careful about using that. And that's the reason I'm not going to focus on it too much in the talk and the presentation here, but just know that it has been evaluated. The others are the high P sequence, which I mentioned earlier when we talked about antecedent-based interventions, but the high P sequence also has consequence-based components to it, so I'll talk more about it here. And then guided compliance, which is a very common intervention for compliance, probably the most common, and then differential reinforcement or contingent access to preferred items is another common consequence-based intervention. Both of those last two have a lot of support. I've just listed a few of the studies that have evaluated them, but there's many more. Both of those last two are well supported. Okay, so we'll talk about, I'll sort of skip the timeout discussion, mainly for the reason I just mentioned, also because a lot of, I think nowadays, at least in Florida, a lot of schools and daycare programs are kind of moving away from using timeout, especially timeout when it involves removing the student from the environment. So some are reluctant to do that, so I'll skip talking about timeout and go to some of these others. The high P sequence, as I mentioned earlier, just involves the presentation of usually 3, although it can be more, but usually 3 high probability instructions right before a target instruction, so the instruction for which you want the child to comply. And the high P instruction, they're called high probability instructions because they are instructions which with the child has a history of compliance with. In other words, they're sort of fun instructions, right? So they might be things like, give me 5, how old are you? What's your name, or what's your teacher's name? They can involve a vocal response. They can involve a motor response. Give me 5. Give me a fist bump. There's all kinds of things that people use, but this intervention actually goes way back to 1988. Was the first time that it was, really even before that, but Bud Mace evaluated it formally in 1988. If you've never seen that study or read that study, you should. It's interesting. It's a very detailed study on a very small number of participants. He had 5 experiments on just a couple of participants, but he looked at in detail. Each experiment looked in detail the conditions under which this person would comply, the types of high P instructions used. And it's very in depth, but essentially they identified 3 things that this. For one of the participants, the individual was likely to comply with, and they formally evaluated those. So they went to caregiver and said, all right, what are some things that some kind of social games that you play, or things that you ask this person to do and he likes to do? And the caregiver came up with like 10 things, and then they evaluated those 10 things. They presented each one individually, and they recorded compliance, maybe presented each one 10 times, and recorded compliance. They empirically could show that, yeah, 100% he complies with this, with give me 5 or whatever it was. 80% of the time he complies with an instruction to, tell me your name. And so they identified 3 of them. All 3 were 100%. Those were their high P instructions. And then they said, okay, I don't think this was mom. I don't think it was a child. It was a teenager or adult. But went to the caregiver and said, okay, what are some of the instructions that you're having trouble getting Mark to comply with? And caregiver said X, Y, and Z. And then they implemented the 3 high P instructions right before the low P, the target instruction, each one of them. And they did get compliance. They found that in baseline, when they weren't using the high P instructions, compliance was low. When they implemented the high P instructions right before the low P instruction, compliance went up. And so since then, since that study, there's been a lot of research on this. It's widely implemented in practice. I know in Florida, I've been shocked at how frequently this is used, both in classrooms, day programs for folks with disabilities, group homes. I've been a lot of places all over the state, and I oftentimes ask people what do they do to increase compliance, and almost everyone says we use the high P sequence. We use high P sequence, and they implement it. And sometimes it works, sometimes it doesn't work as well. But it's definitely widely used. It's at least down there. Let me show you an example. So, the instructions as I mentioned, they have to be sort of fun, things that the kid likes to do, the child likes to do. And another key component of it is the inter-instruction or inter-high P instruction interval. Like you notice that she delivered them pretty quickly, almost back to back. So with maybe a 1 or 2 second inter-instruction interval there. So she delivered one, she waited a second or two, and then delivered the other. There's been some studies evaluating that, actually looking at, does it matter if the inter-instruction interval is only 1 or 2 seconds, or if it's 10 seconds or 30 seconds? And yes, it looks like it does matter with a lot of participants. The shorter the interval, right, the more likely you are to get compliance than with the low P instruction. In that example, the low P instruction was handing over the iPad. So the shorter the interval, the better. There's been some other things that have looked at with respect to that, that I'll talk about in a minute here. Okay, so here's some data from a study that we did evaluating the high P sequence. Even though in many cases it's been shown to be effective, it's not. In some cases it hasn't been shown to be effective. This is one such case. There was also a study by an author I mentioned earlier, Ray Miltenberger, who did some high P research back in the late 90s, and some of his data show that it's not always effective. On the graph that you see here, the HI-P is the high P phase. And so you can see with the first participant, the high P phase was, I can't see it, but somewhere around here in the middle. And note the data path you're looking at is compliance. So sessions on the X and percentage of compliance on the Y. No increase in compliance with the high P sequence. And we had to go to, it's labeled as EXT, extinction, but it's really a guided compliance procedure that I'll talk about in a few minutes. We had to go to that procedure to get compliance up. For the first 2 participants, that was the case. For the bottom panel, for this participant, the high P sequence did work. We actually tried something else before that. If you remember earlier when I mentioned, was talking about antecedent-based interventions, I mentioned that giving the child, in some cases, a preferred item before delivering the instruction has been evaluated. And so that's what we evaluated here in this NCR condition. That didn't work. And then we went to high P, and that did work. So, like a lot of things, the effects are probably idiosyncratic. It probably depends on the individual, the child that you're working with, but it can be effective. This is an example of a data sheet. Now we use, when we're at the Scott Center in our clinic, we have iPads that we collect data on, but the iPad essentially brings up a data sheet that looks like this. When we're using the high-P sequence, it's important I just wanted to bring this up because it's important to collect data on compliance with each of the high-P instructions as well as the low-P instruction, right? Even though you're mainly interested in compliance with the low-P instruction, if they're not complying with the high-P instructions, then the integrity of the procedure is compromised. You're not really doing the high-P sequence, right? If they're not complying with, give me 5, what's your name, et cetera, then you shouldn't expect it to work. So we have our therapists, when they implement this, take data on each of the high-P as well as the target or low-P instruction, and then they also record any other problem behavior that might occur. So I mentioned earlier that there's some other kind of parameters of that sequence that have been looked at in addition to that intertrial interval. So that's important. It should be short. The shorter, the better. Another parameter that has been looked at, that we looked at recently, was whether or not you have to deliver a reinforcer for compliance with the high-P sequence. So, a lot of times in practice, what will happen is that the high-P sequence will be, the high-P instruction will be delivered, and then the therapist will just move on quickly to the next high-P instruction. Sometimes they won't even deliver social praise, right? Sometimes they will say, oh, good job, great. Or they'll, in some cases, may even deliver some brief access to a tangible item or an edible item or something. But probably in the majority of cases, either nothing is delivered or it's just social praise. They'll quickly move on to the next instruction. And so we wanted to see how important that was. That is does it make a difference if after each high-P instruction, if you deliver some type of reinforcer before moving on to the next high-P instruction? Does that make a difference on compliance to the low-P instruction? So we had two experiments in the study. And in the first experiment, we looked at that is whether or not if you just move on quickly without delivering any sort of reinforcement after the high-P instruction, we compared that to a condition in which there's some sort of reinforcer, and we evaluated the reinforcer before the study began, either social praise or an edible item delivered after compliance with each high-P instruction. And we found that it did make a difference, for these 3 kids at least. The high levels of compliance are the conditions. I know it's hard to see the condition labels here, but sessions on the X, compliance on the Y. The high levels of compliance are the conditions in which a reinforcer was delivered contingent upon compliance with the high-P instruction. But all these data are data for the low-P instruction, right? So everything that's graphed is whether or not they complied with the low-P instruction. But the difference between this and this is that in this condition, a reinforcer was delivered after the high-P instruction, after each high-P instruction. And so it did make a difference for all 3 of these kids. You can see these, the conditions in which compliance was high were those conditions in which the reinforcer was delivered. Then in the second experiment, in the same study, we evaluated the quality of the reinforcer. Right, so I mentioned earlier that in some cases in practice, I think a lot of times folks will, if they deliver anything, it'll be praise. But in other cases, folks may use something like teachers, parents, et cetera, may use an edible item or a brief access to a preferred toy or something. So we evaluated whether praise is as effective or more effective, or perhaps less effective, than delivering a more highly preferred item. In this case, it was an edible item. So before we ran these data, we did a preference assessment, and we compared praise to edible items. Both kids chose the edible items. It was more preferred. The edible item was more preferred than praise. And then, so once we had that information, we went ahead and implemented the high-P sequence, sessions on the X, compliance on the Y, and you're looking at compliance with the low-P request here. And in the conditions in which praise was the reinforcer delivered for compliance with the high-P instructions, we got low levels of compliance. And then when we moved to the higher quality reinforcer, and that's defined by the preference assessment that we did before. They preferred the edible items to the praise. We got increases in compliance, and that was the case with both kids here. So that just suggests, again, it's only 2 kids. You can't make any sort of general statements about that, but it does suggest that not only is delivering reinforcement for the compliance with the HIP instructions important, but the type of reinforcement that's delivered might also be important, right? The more preferred, higher quality reinforcers might make compliance with the LOPRI request more likely. All right, so I'm going to talk about guided compliance next, and before I do, I'm going to show you an example of it. Guided compliance, it goes by a number of different names. Some of you may know it as, may have heard it referred to as the 3-step procedure, 3-step prompting, physical guidance, sometimes people call it. Guided compliance is probably the term that's most used in the literature, but it's really all the same thing. It consists of 3 levels of prompts, right? So you deliver the instructions to the child, first deliver the instruction. If the child doesn't comply within some period of time, you then go to a vocal plus model prompt. Then give the child usually 10 seconds to comply. If no compliance after the 10 seconds, then you go to a vocal plus physical guidance prompt, right? And then what you're measuring all along is compliance with respect to the first instruction. So what you want to see is, does compliance go up when you first deliver the instruction if you use this 3-step procedure? It's called guided compliance because in the final procedure it involves physical guidance in addition to the vocal prompt. So it looks something like this. This child is funny. By the way, we have permission to show him on the video from his parents, but he has an autism diagnosis, but he's got very good listener repertoire, very good receptive language skills, but he's completely nonvocal. Has never said anything. He has a communication system that he uses on the iPad to communicate, sort of a PEXT iPad-based system, but completely nonvocal. But he's fun to work with. Anyway, in that guided compliance procedure, she didn't wait, because for illustration purposes, she didn't wait the required amount of time between the prompts. Usually you'd wait about 10 seconds to give the child time to comply with each prompting level. But the gist of it is what you saw: vocal instruction first, vocal plus model next, and then if no compliance still, vocal plus physical guidance. Also, another thing that she should have done there is in the vocal plus model prompt, you might have noticed that he didn't look at her, he didn't make eye contact with her. And if you would expect, if you want the model prompt to be effective, then the child has to be looking at what you're doing when you're modeling it. You want him or her to imitate what you're doing, so they have to be looking. But she didn't get his eye contact first. So if you're implementing it, you would in that middle prompt you would get eye contact first, and then go ahead and model it, and then if no compliance, wait 10 seconds. If no compliance, then vocal plus the physical. So this has been evaluated in a number of studies. I'll show you some data from a couple. These are data from about 10 years ago that we collected in a preschool. We had 6 participants and multiple baseline design. Sessions are on the X and percentage of compliance is on the Y. 6 participants are here. The procedure worked with 4 of the participants, so the first panel, third panel, 5th, and 6th. It didn't work with 2nd and 4th, and we had to go to a different intervention. We had to go to differential reinforcement, which I'll talk about next, because the guided compliance procedure didn't work. But for 4 of the 6, it worked, not bad. One of the things I want to point out, though, is that for at least 2, look at panels 5 and 6, for these 2 kids, so no compliance at baseline, virtually no compliance for either kid in baseline. We started implementing the guided compliance procedure and got an increase, but it was, notice that it was a relatively slow increase. So on the y-axis here, 100 is up here, right? So there's two things interesting here. One, we didn't get compliance to 100%. We didn't get perfect compliance ever with either kid. And although we did get an improvement, certainly better than baseline, it was slow, especially in the beginning. And that is the pattern I've noticed. That is a pattern you see with a lot of kids when you use this procedure, is that when you first start implementing it, you get some problem behavior, right? Because especially if you have to go to the third step, the kids don't like being physically guided. Many kids don't like being physically guided to do something, so you get some problem behavior. If you continue, oftentimes the problem behavior will abate, and you start getting compliance, but it's really slow. Often, sometimes it takes 40. Each of these sessions represents 10 trials. One data point, represents 10 trials. So, this is 40 trials, and we're up at about 50% compliance for this participant, and about the same here. So that's a lot, right? Trial after trial, and in the real world, you're not. This was research, so we were doing the trials on the time between trials was fairly short. But in the real world, the time between trials is not likely to be that short. So the point is that sometimes this intervention may take some time to work, if it does work. And it often does, essentially because the child is learning that there's no way that I can avoid or escape this task. If mom asks me to do something, or if teacher asks me to do something, I'm going to have to do it, so I might as well just do it initially on the first request, because then that way I can avoid having the physical guidance. I want to go through the physical guidance. So oftentimes it does work, but it might take some time. It might also evoke some problem behavior. Another problem with it is that in many settings, at least in my state, especially school settings, many school settings nowadays, there's a hands-off policy, or at least a partial hands-off policy. You've got to be careful about the conditions under which you can put hands-on. And in this procedure, especially if the instruction involves a motor response, you do have to physically guide it at the third step. So that can be an issue.
In this test, you talked about differentiating whether the problem was with the vocal repertoire versus motivational. So I would think is this procedure useful for both, or is it mainly for kids who don't know the instruction very well? So you're teaching them to them?
Yeah. Good question. So the question was, at the beginning of the presentation, I talked about when you're doing an assessment, it's important to differentiate sort of the root cause of the compliance problem. If the root cause is an inadequate listener repertoire, then that suggests one intervention. If the root cause is a problem with reinforcement, there's not sufficient reinforcement to evoke the compliance, then that suggests a different intervention. But the question was, with guided compliance, wouldn't that intervention be appropriate for both of them? And the answer is yes. And that's one of the benefits of this intervention, that this, or maybe something close to this intervention, would be appropriate for kids who have an inadequate listener repertoire, as well as kids who have a problem with the reinforcement's not sufficient. Because what you're doing essentially in this guided compliance procedure is teaching the motor behavior that goes along with the vocal instruction, right? You're teaching the child that when I say, give me your toy, what I mean is that you have to pick up the toy with your hand, move your hand over towards me, and drop it in my hand, right? You're teaching them that my vocal, those words, mean this motor response. So it can be used with kids who have an inadequate listener repertoire, as well as those who have problems with reinforcement. And for the main intervention, though, that's if you're certain that the listener repertoire is problematic, you might use an intervention that involves prompting, reinforcement, and maybe some more modeling, right? So in other words, you might insert a few additional prompts before you go to the physical prompt, and you may eventually still have to go to the physical prompt, but it might be, you may be able to avoid quickly going to the physical prompt by inserting some prompts before the physical prompt if you're certain that the listener repertoire is problematic. This is an example of a data sheet that we use. Again, we collect data on iPads at our clinic, but I wanted to show it to you because like the high-piece sequence data sheet, we always have our therapists collect data on compliance at each level, right, when we're using the guided compliance procedure. I mentioned earlier that mainly what you're looking for is compliance with the first prompt, the first vocal prompt. That's what you want because that's what kids who are compliant, that's what it looks like when they're compliant. So an adult asks them to do something, they do it with the first prompt or with the vocal instruction. So that's the main sort of target dependent variable you're interested in. But you also oftentimes want information on whether or not, if they didn't comply with the verbal prompt, whether or not they complied with the model prompt or the physical prompt, the physical guidance prompt. So if you have a data sheet that enables you to take data on compliance at each level, if you have to move up that hierarchy, then you can look back and say, well, he's still only compliant on the vocal prompt maybe 20% of the time, but now his compliance with the model prompt is up to about 80%, whereas earlier it was down at 40%. So there's some improvement, right? So just another way to evaluate whether or not you're getting some improvement with respect to compliance at each of the levels. Okay, one of the things we found with, I told you I'd talk about, show you two data sets with respect to the guided compliance. One of the things we found with guided compliance is that in some cases, the model prompt, so again, vocal plus model, and then vocal plus physical, the model prompt, the middle prompt, may not be necessary, and in fact, it may even be causing a problem, may even make compliance less likely for some kids. I'll show you some data on this, but this came about because we were, especially with sort of the kids with better language skills, we at our clinic, we have this kind of blanket, for a while, we had this blanket guided compliance procedure in place. So everyone gets when they come in, everyone gets the guided compliance procedure, regardless of assessment and what the assessment results show, and et cetera. And we do something different now, but initially we had that in place. And we were noticing that with the kids who had better language skills, oftentimes the model prompt seemed to be enabling them to avoid or escape the task for a little bit longer, right? So if you think about the procedure, it's at least a 30-second long procedure. There's at least 30 seconds there where the child doesn't have to comply. He can just sit there and not do anything because you're going through this this 3-step procedure. And so we were noticing with some kids that middle prompt there really was just enabling them. When the therapist would say, do this like me and model it, the child would either would look and then continue with playing with the toy if that's what they were doing, or continue in some other activity and not comply. And it almost seemed as if we were just enabling the child to avoid the task, the instruction, for a little bit longer, 10 or 15 extra seconds. So we cut out, for some kids, we cut out that, we made some modifications to the procedure. One of the modifications was we cut out that middle prompt. So now it's just a 2-step guided compliance procedure. Easy to understand, but I'll show you an example. So again, the model prompt was just eliminated. Here's some data we had 4 kids in which we evaluated this. This was a study published in JABA a couple of years ago. The first phase, sessions on the X, trials of compliance on the Y. So we're looking at the open circle, or the closed circles are compliance. First was baseline, low levels of compliance. We implemented 3-step. It improved a little bit, but not substantially. And then we dropped the model prompt. So we went to the 2-step compliance procedure, and it went way up. Compliance increased. Back to baseline, low levels, and then back to the 2-step, and it went way up. So it appeared that for that participant, that the 2-step procedure, where we dropped the model prompt, was more effective. Again, anecdotally, it looked like he was just, we were enabling him to, in this case, the instruction was to hand over access to a preferred item, hand over access to a toy. So we were enabling him to maintain access to the toy for an extra 10 seconds or so by using the 3-step as opposed to the 2-step procedure. For this participant, baseline compliance was relatively low. 3-step didn't work very well. Back to baseline didn't work. The 2-step procedure didn't improve it much, a little bit, but it's not up at 100%. So we made another modification, and by reducing the amount of time between the prompts, right, the interprompt interval, 10 seconds is kind of the modal, as I've said earlier, the amount of time that you want to allow the child to comply. But for some kids, 10 seconds may be too long. And so we, in addition to changing the number of prompts, we reduced the interprompt interval to 5 seconds, and that seemed to help. It got it up some, we went back to baseline, and it came down, and then back to the 2-step with the abbreviated interprompt interval, and that was effective. So the point here is that a lot of places use this 3-step guided compliance procedure if they can, if there's no hands-off policy in place. I've seen it used a lot. If it's not working, though, there's some things you can do to modify it to make it more effective, right? Things like reducing the model prompt or reducing the interprompt interval. These are 2 additional kids from the same study. Unfortunately, for these 2 kids, neither of those worked. We tried the 2-step and we tried to reduce the interprompt interval, and it didn't come up, compliance didn't come up, so we had to go to another intervention, difference reinforcement, which I'll talk about next. Before I do, quickly though, before I get into differential reinforcement, another issue that often comes up, not just with guided compliance, but with really all interventions, be they for compliance or for another behavioral skill deficit or behavioral excess, is how well they're implemented. So some of you may have seen Willie DeLeon's talk yesterday. In the afternoon, I saw that, and he made a comment about, I think it was extinction. And he said, in the real world, extinction as an intervention is just never implemented as it's supposed to be implemented. It's just impossible. It just never gets done. You can describe it, you can model it, you can teach people to do it until they meet a mastery criterion, but it just, in the real world, things happen, and it's just never implemented as it should be. So when I completely agree, that's true, especially, and it's true with extinction. I think it's also true for this intervention, guided compliance. We evaluated that. We wanted to see, we were thinking that in the real world, it's unlikely that a caregiver, parent, or teacher, therapist can implement this procedure with perfect integrity, meaning they can do it perfect every time, right? So we wanted to see if we intentionally reduce the integrity, how well it's implemented, how much will that affect compliance on the part of the child? So we had 2 kids, 2 participants, and we had 3 levels of integrity. We had a perfect level, 100%, so the therapist implemented the guided compliance procedure perfectly every time they delivered the instruction. We had a 50% level in which every other time the therapist implemented the guided compliance procedure perfectly, but every other time she didn't. That is, every other time she delivered the instruction but then didn't deliver the model prompt or the physical guidance. So that was the second condition. Then we had a third condition that was 0% integrity, meaning essentially it was just like baseline. All the therapist did was deliver the first instruction and never did, on any trials, the model prompt or the physical guidance. And so baseline, you can see that compliance is relatively low, and there's 3 baselines, and they correspond to each of the 3 conditions I just talked about, 100%, 50%, and 0%. And you can see in intervention, when the guidance compliance procedure was implemented, we got the most compliance. So the y-axis is compliance on the part of the child. We got the most compliance in the 100% condition. We got kind of mid-level compliance in the 50, and very little compliance comparable to baseline in the 0 for both kids, high, medium, and low, which is really what you would expect. That is that the more exact that the procedure is implemented, the better compliance will be. And as the integrity goes down from 100 to 50 to 0, you get lower levels of compliance. Bless you. Unfortunately, you may expect that if you're telling a parent or a teacher or caregiver you're teaching them to implement this procedure and they don't do it perfectly, don't expect perfect levels of compliance on the part of the child. Okay, I'm going to talk about difference reinforcement. I have a video clip, but I'm not sure it's necessary to show it. I have one using tokens. I will show that in a minute. But essentially, difference reinforcement just involves reinforcing compliance and placing noncompliance on extinction. To implement this procedure, of course, you have to know what the function of compliance is, right? You need to, in other words, you have to have the results of the FA that I talked about earlier. If compliance is maintained by attention, then the reinforcement that you provide for compliance should be some form of attention. And for noncompliance, the program consequence should be no interaction, right? No attention. If the reinforcer is avoidance or escape from the task, the reinforcer in the DRA procedure should be not having to do, so the child complies and then gets out of the task for some time, gets to avoid or escape it for some period of time. And the program consequence for noncompliance is physical guidance, right? Physically guiding the child to comply with the task so that noncompliance is placed on extinction. So this, along with guided compliance, are the two interventions that have been shown generally to be most effective. And there's been a number of studies evaluating each of them. Here's some data from one study. You could ignore the bar graphs on the left. Those were FA data. The graphs on the right are intervention data for two participants. Both participants' behavior was maintained by access to preferred items, and so the DRA procedure consisted of, contingent upon complying with the instruction, the child got child was given tokens. These kids had good language skills, were very high functioning, even though they had a disability and autism diagnosis. But they can understand and use tokens very well. So we set up a system in which each token equaled 5 minutes access to the preferred item, and contingent upon complying with the instruction to relinquish the preferred item, they got a token, right? So once they collected the tokens, that equaled a fairly long period of time. They could then exchange the tokens for a long period of time with access to the preferred item. And that was pretty effective for both kids, even though the instruction was to relinquish the preferred item, right? So essentially what you're pitting very brief access to the preferred item against a long period of time in which they get access to the preferred item in the DRA condition. And for kids who have, I think, good language skills, that usually wins. The long period of time typically wins out. For maybe lower functioning kids, that's probably not always the case, and you might have to add something to the intervention or select another intervention. But that's what we've found. This next study was published in Education and Treatment of Children a few years ago. And I highlight it because we had 3 participants, and we wanted to, because the two most common and effective interventions have been the guided compliance and the DRA, the contingent access, we wanted to compare those. So in 3 participants. So we have baseline here. Data on the left are compliance, data on the right are problem behavior. So for the 3 panels on the left, there are 3 different kids. Baseline, low levels of compliance. The CA condition just means contingent access, or meaning that if they comply, they get access to a preferred item, which is the same thing as DRA. Back to baseline, and then we went to the guided compliance, or it's labeled 3S, a 3-step. It's another name for the guided compliance procedure. You can see that for all 3 kids, the contingent access condition was more effective here than the guided compliance or 3-step procedure. So there's been a couple of other studies comparing these two, kind of most effective interventions, and with a lot of kids, the differential reinforcement or contingent access often wins out. It's often a little bit, it may be better than the guided compliance procedure for a couple of other reasons. I mentioned earlier that with guided compliance, some schools in particular have hands-off policies, so you may not be able to use it as often. But there's some downfalls to differential reinforcement as well, sometimes you can't identify things that function as very powerful reinforcers, right? So whatever you come up with may not be as powerful as maintaining access to, let's say, a preferred item if the noncompliance is maintained by access to, if the instruction involves relinquishing a preferred item and the noncompliance is maintained by holding on to that, you may not be able to identify anything that's more powerful than that. And if you can't, then DRA is not likely to work. It's probably not going to be effective. Another kind of problem with DRA sometimes is that if you're using, if the child you're working with has the language skills such that you can teach tokens and token exchanges, it's easier. But if they don't, or if that's difficult to teach, then sometimes that can pose problems and be difficult to get DRA to work. Just like with guided compliance, the effectiveness of DRA probably depends on how well the parent or teacher or therapist implements it, right? And there are two errors that can be made in the context of differential reinforcement. Some of you may have heard about these. One error is an error of omission, in which you're supposed to deliver the reinforcer for some target response, in this case compliance, but you don't, right? So if I'm mom and my child, I present an instruction, my child complies, some of the time I'll deliver a reinforcer, be it praise, an edible, access to a preferred item, what have you, but at other times I won't. I'll just forget, which often happens in the real world. I'll just forget to do that. So those times in which I forget would be called an error of omission. Another type of error that can be made is an error of commission, and that error refers to situations in which I'm mom and I provide the reinforcer, whatever it may be, independent of compliance, right? So I deliver, even, I say, all right, Sarah, do X, and she doesn't do X, but things are busy, and I just deliver the reinforcer anyway. I'm not even attending to whether or not she complied. I just deliver it. So that type of error is an error of commission. So we wanted to look at, how important are these two errors in the context of DRA for compliance? If you make a lot of these errors, will that decrease compliance on the part of the child a lot, or will it not affect it much? And also, which of these two errors is more important? Does an error of omission mean, is that more detrimental to compliance than an error of commission? So if you're interested, this study is in Journal of Behavioral Education. It was published a couple of years ago. I'll just show you some of the data from it. This was one participant. Annie was her name. Compliance is on the Y, sessions are on the X. The conditions labels here, where it says baseline, each of these phases was just a baseline phase where the therapist just presented the instruction. 100% means that, and this, by the way, this one focuses on errors of omission. I'm going to talk about commission next, but this is the error of omission study. So when the therapist just forgets to deliver the reinforcer on some occasions. So in the 100% condition, that's perfect implementation. Every time compliance occurred, it was reinforced. Therapist delivered the reinforcer. In the 20% condition, only 1 out of 5 trials in which compliance occurred was a reinforcer delivered. In the 60% condition, 3 out of 5 trials in which compliance occurred, a reinforcer was delivered. And as you might expect, high compliance in the 100, no compliance in the 20. This is a little surprising. High compliance in the 60, at least here, and then kind of moderate levels, but still fairly high in the 60 here, always high in the 100. Another thing that's kind of interesting about this is that after we did, you might notice that the alternation schedule was baseline 100, baseline 20, baseline 60. Over here, we implemented 100% compliance conditions between the 20 and 60. So the idea there was that it might make a difference if the child has a history of always getting the reinforcer for compliance and going from that situation, that condition, to one in which they rarely get it, right? To like 100% to a 20% condition. So at home, this might something like this might happen when mom first implements or teacher at school first implements the DRA procedure with perfect integrity. Therapist trains her, she's doing it perfectly. Then, as time goes on, other things get, happen, and other things become more important, and integrity kind of starts to slip, right? So does it make a difference if the child has a history of perfect integrity first and then is exposed to a situation in which integrity is not as good? So that's essentially what this is. 100% integrity first, followed by 20, back to 100, followed by 60, back to 100, followed by 20. And the differences between this and this are not that great. 100% was always high, 100% here, 100% here, 100% over here. 60% or 20% was always low, right? Low here, and it's low when it was preceded by baseline over here. But 60% was often higher when it was preceded by 100% versus when it was preceded by baseline. In other words, and I'll show the next data set kind of supports this too. It's the same thing, but it may be a little clearer. Just suggests that when compliance is preceded, when DRA is used and the integrity is not that great, but it's preceded by a condition in which integrity is really good, the detrimental effect may not be as large, right? In other words, if you can get parent or mom or teacher to implement the procedure initially really well, if they then start making some mistakes after they've implemented it well, it may not be that bad. But if you can't get them to implement it very well to begin with, then you're not going to have good effects on compliance. So it's kind of good news in the sense that if you can initially get it up, that integrity up, that you may be okay. This is the same, different participant, but we did the same thing, and it just supports what I just said, that for errors of omission at least, it looks like that, as you might expect, integrity matters, and if you implement right before a low integrity condition, if you implement one in which the integrity was very high, it may be less detrimental. Here's the data. I just have one graph for the errors of commission data. So remember, this is the other type of error you can make with DRA, in which, as mom says, do this, and even if the child doesn't comply, mom still delivers the reinforcer. She's busy, and she still delivers it anyway. Error of commission. So we also wanted to see what effects errors of commission would have on compliance. Baseline low levels of compliance, 0% errors, meaning perfect integrity, increases in fairly high levels of compliance. 100% errors, nothing, no compliance at all. Back to 0, much better, and then 100% nothing, and then 0%, it's better. So in this study, in this experiment, we didn't manipulate. We didn't go 100, 50, 0. We didn't have time to do that. We just wanted to see what would happen if it was all or nothing. And as you might expect, errors of commission were important too. That if the therapist consistently made an error of commission, low levels of compliance. If they did not, you get higher levels of compliance. So I talked about consequence-based interventions for the most part now. We went over 3 of the major ones: the high-piece sequence, guided compliance, and differential reinforcement. In some cases, you may have to add, though, right? Add interventions. So at the Scott Center, if we start with one of those, let's say we're starting with the high-piece sequence and that doesn't work, sometimes we'll then go to another intervention, let's say guided compliance, and maybe that's somewhat effective, but it doesn't get compliance up as high as we'd like. So then we'll add maybe guided compliance plus differential reinforcement, right? So in some cases, we may have to add on an intervention to increase the effectiveness of the procedure. So there's been a couple of studies showing that an intervention by itself is maybe less effective than when you add an intervention onto it. There's a couple of these graphs just depict that. Here we have a guided compliance procedure. First, we tried differential reinforcement by itself. It wasn't as effective. Then we added the guided compliance. And guided compliance for this child actually was effective. But for the next 2 kids, differential reinforcement first wasn't effective. Guided compliance by itself was not very effective. So we added guided compliance plus differential reinforcement, and that was effective. That got it up. So the point is that in some cases, you may have to think about, once an intervention doesn't work, if it's at least somewhat effective, not tossing it, don't throw the baby out with the bathwater, but add on to what you've already got, and you may be able to get compliance to very high levels. And this shows the same thing, essentially. All right. I have some. It's almost 4 o'clock, and I think I may have about 5 minutes or so to get. I have a decision tree, a compliance intervention decision tree that I developed for. Essentially, it's just a tree that suggests interventions to use given certain conditions. So I want to save time to get to that in the end here, but. One of the things that, as I've been talking about interventions for compliance, that you may have noticed is that almost all of these interventions involve training someone to do something differently, right? Either mom or teacher or caregiver or whomever. And so another issue that often comes up is, well, what happens if you train, or what kind of procedure should you use to train the caregiver, parent, or teacher to implement, say, DRA or guided compliance or the high-P sequence? What's the most effective way to teach them to implement an intervention with the child, right? So this was a study in which we used behavioral skills training. Some of you may be familiar with that. The acronym is BST. Behavioral skills training, which is a fairly strict set of procedures that are used to teach all kinds of things, but we used it to teach guided compliance to parents, and it involves essentially telling the parents about the procedure, how to implement it, and then modeling it for them, and then letting them do it, and then giving them feedback, and then requiring them to get up to meet a mastery criterion before letting them do it on their own, right? Before leaving them essentially and saying, okay, you've got it, you're on your own, implement it with your child. So oftentimes the mastery criterion is like 80% correct steps across, let's say, 4 out of 5 implementations. So we make sure that they can get correctly implement the procedure 4 out of 5 on 4 out of 80% of trials, 4 out of 5 trials across 3 out of 4 sessions, right? They have to do that. Once they're done, then we say, okay, you're good to go. These are just some data showing that that can be effective. These are, instead of kids now, these are parents. 3 parents, mothers on their data are depicted on the sessions are depicted on the x-axis, but their data are depicted in the panels. And this is the percentage of correct implementation on the y-axis. And so we essentially just asked them to implement, this was guided compliance, asked them to implement the procedure without giving them a lot of instruction. And as you can imagine, it wasn't very good. They were only getting about 30 to 40% correct, and these two were even less. And then we did the BST training and got it up to close to 100%. And then the last data point over here is a follow-up. So we had actually a 3-month and a 6-month follow-up. I don't have all the data showing, but a 3-month and a 6-month follow-up data point to be sure that they were still implementing it correctly. And they were with that, with the BST model. I think the crucial component of that is the mastery criterion, right? That, it's a lot of times when, at least at the Scott Center, when we train parents, if they don't have time to go through all the training and they don't get the mastery criterion components, I think implementation is poor. The integrity is poor. They don't do things as well. But if we can make sure that they meet that mastery criterion, 80% or greater, across 4 out of 5 sessions, then oftentimes it sticks. They implement it well. The integrity is good, and this just illustrates that. So the take-home point for the presentation is I'll just review what we talked about quickly here. Compliance is, I talked initially about how compliance is a crucial skill. It's a critical skill. It's often seen as a behavioral cusp, particularly for kids with autism. It's correlated with a lot of other bad things later on in life. Our non-compliance problems and non-compliance early on are correlated with a lot of other bad things later on in life. It should be a focus of instruction at home. It certainly is in a lot of EIBI programs, but I get the sense that it's not often a focus of instruction for kids who don't go that route. That is, who enter kindergarten or enter preschool without having the benefit of an in-home or a center-based EIBI program. But they should be getting that. In whatever setting, that the problem occurs, the noncompliance is occurring, there really should be a focus on that, increasing compliance, increasing that skill, because it's very important. And we talked about assessment of compliance, the three things that need to be considered when doing the assessment. First, the listener repertoire. Second, compliance to what instructions, with whom, and how often, the conditions under which compliance occurs. And three, if necessary, a functional analysis to determine the reinforcers that are maintaining noncompliance. And then we talked about interventions, and we categorized the two broad types of interventions, antecedent-based and consequence-based interventions. And we said that, in general, consequence-based procedures are more effective than antecedent. There's a lot of antecedent-based procedures that have been implemented. Some of them are more effective than others. There's a few that have sort of mixed support. There's some more that have fairly solid support, but really the consequence-based procedures are the most effective. And in particular, the guided compliance procedure, or three-step prompting, and DRA, differential reinforcement, or contingent access to items, have been shown to be the most effective procedures overall. So I'm going to show you the compliance tree. I've also got a handout with the compliance tree on it for those who are interested. I don't think I have enough for everyone, but I do have enough probably for those who are interested. You can also email me, and I can send you a copy of the compliance tree. Yes? Yeah, the person who's probably done the most work on that is Ray Miltenberger. He's not in the context of compliance, but he's used it to teach all kinds of skills, like oftentimes to kids without disabilities, like what to do when lost, or what to do when you see a firearm. So he uses that BST model to teach kids typically what not to do when they see a firearm, or what to do when they're lost at a store in the community or thing. But that model itself has been used to teach a number of things, and it's a good one. It's what we use at the Scott Center, especially when we have that mastery criterion. That's an important component of it. I think there was another question. Oh, I answered it? Okay. Okay, so here is the compliance intervention decision tree. So it basically starts out, it's a series of questions, and depending upon the answers to the question, it suggests an intervention. So as an example, the first question is the individual's lack of compliance interfering with his or her educational learning opportunities? Yes or no? If the answer is yes, go to number 2. If no, stop. No intervention is needed, right? So if, in other words, if the non-compliance is so mild that it's not interfering with anything, there's probably little reason to intervene, and perhaps not much else to do. If it is a problem, that is, it is interfering with things, then question number 2 is, does the individual have the skills to respond appropriately to instructions or demands? In other words, this is getting at the listener repertoire, right? Is it clear that the child has the skills, can understand, so to speak, loosely speaking, instructions? If it's very clear, then you go one way. If it's not clear, then you need that assessment of their listener repertoire, right? Because it could be that we see this a lot at the Scott Center, that some kids, you'd be surprised, they can understand fairly and respond effectively to fairly complex instructions in some context, for some things, but in another context, or if you're dealing with different items, different stimuli, or with different people, their ability to respond effectively just plummets. There's some odd stimulus control there. There's something about the one environment that's really got tight control over their behavior, their compliance, but then get them in another environment with different people or different stimuli or different instructions, even if you're using some of the same language sometimes, and it just falls off. So that needs to be assessed if there's any concern or if you suspect that the listener repertoire is not adequate. The next question is, can you physically guide the individual to perform the task you are asking him or her to do in the instruction? So this is getting at the guided compliance intervention. If the answer to this is no, and that's certainly possible, as we said earlier, there are a number of settings in which you can't use physical guidance. then that's ruled out as an intervention. There's nothing you can do there. If the answer to that is yes, then guided compliance might be a viable intervention. The next question is, does the individual have the listener receptive language skills to appropriately respond to specific instructions that you're providing? And again, that's getting at the listener repertoire. The next one is, can you or is it appropriate to immediately deliver tangible or edible items contingent upon compliance? That's getting at the DR intervention, the difference reinforcement intervention, DRA. In some settings, you can't. Immediately, contingent upon compliance, it's not appropriate or it's not possible to deliver, say, an edible item, right? There's some school settings and perhaps some parents might object to the use of something like that. So that, in some cases, that intervention may be out and you have to go to something else. The next one is, can you or is it appropriate to immediately deliver items that can be exchanged for preferred items at a later time? And so this is getting at DRA with the tokens, right? Because especially if a child has sufficient language skills such that they can respond effectively, exchange tokens, then DRA using the token procedure is probably a good way to go because it's often effective. Next question is, can you or is it appropriate to deliver high probability instructions before a target instruction? And even though we talked about the high P sequence and said that it's sort of mixed, so research has shown mixed effects, it's often an intervention that's pretty socially valid. That is, there's unlike sort of the guided compliance procedure and sometimes DRA, the high P sequence is most people approve of it. There's not a whole lot of people who would say, well, I don't like asking my son to do 3 things that he likes right before you ask him to do something he doesn't like. Not many people have a problem with that, especially if the end goal, of course, with all these procedures, the end goal is to get compliance, to get the intervention to a point where you don't have to use the 3 high P instructions, or you don't have to use the model and the physical prompt, or you don't have to use the edible reinforcer contingent upon compliance, right? You want to get to the point where they comply with the first instruction. So if that's the end goal, most people don't have a problem with delivering 3 high P instructions first, but in some cases they might. So depending upon your answer to those questions, the tree kind of guides you to an intervention. And so I developed this thinking that it would be useful, and I think it is, especially for kids who've got sort of mild levels of compliance problems, but with the heavy hitters, the ones that are non-compliant with all sorts of things and or have other behavior problems, then really you need to go through that series of assessments that I talked about earlier, assess the 3 things, and then develop an intervention based on the results of those assessments. But the tree might be useful for some of you, for some of the kids you work with. So I will pass out some of these flyers. It's the last, on the handouts I've got some questions, and then on the last page is the decision tree. So if you're interested in that, you can take it. It's 10 after, so we have about 5 minutes for questions if there are any. Yes? Okay, yeah, good question. So if you didn't hear that, the question was, what's your opinion, or what do you think about, or what happens, or what are the concerns with situations in which compliant behavior, non-compliant behavior results in reinforcement? That is, you've put an intervention in place, and parent or teacher, even though they're trying to implement it well, just don't implement it perfectly. So it at least occasionally still results in reinforcement. And compliance also results in reinforcement. So you've got 2 sort of schedules there occurring that are co-occurring, right? So in one schedule, the child complies, there's reinforcement delivered. And in the other schedule, the child doesn't comply and sometimes does get the reinforcer. that I think that often happens in the real world, and as long as you can, in situations like that, it becomes a matter of sort of stacking the deck, right? As long as you can stack the deck in favor of reinforcement for compliance, then you should be okay. You may not get intervention effects that are as quick or as large as when perfect extinction is in place, when you're not reinforcing noncompliance at all. But as long as either the amount of reinforcement or the magnitude, or in other words, what the child gets, as long as that's greater for compliance than it is for noncompliance, eventually the child should learn that that's the response that he or she wants to make. In other words, that'll win out over the long term. But that's a common issue. And so you have to start thinking about how are you going to stack the deck? How are you going to make the reinforcement for compliance greater or larger or more frequent than it is for noncompliance, knowing that it is going to occur sometimes for noncompliance? Does that answer your question?
I have a little bit of an example of that. When we were potty training my son, we cut mints into 4 quarters. When he would apply, we would give him the full mint. When we wouldn't, we would just put in little pieces, trying to calm him down.
Yeah, good example, right. So he got more for...
Applying, got the full mint.
Okay, good, yeah. Another sort of interesting bit of information that relates to that is in a recent issue of JABA, there was a study in which those of you who work in early intervention settings might know the practice of, and this doesn't necessarily relate to compliance, but when you're teaching any skill, if the skill that you're teaching, you present the instruction and the child has had a history of not getting it correct, but this one time and you present the instruction and they get it correct, a lot of times therapists will deliver a higher magnitude reinforcer for that, right? They'll either, whatever the reinforcer is, they'll deliver more of it. Maybe it's praise, maybe it's an edible item, maybe it's access to a toy. They'll up the magnitude for that. And so this study looked at whether doing that was more effective than just delivering a regular, average magnitude reinforcer for that sort of novel or unusual correct response. And they did find that learning occurred more quickly when the therapist upped the ante, upped the magnitude. So in other words, that does seem to be effective, at least with the kids that they use. There's only a few kids, but. Any other questions? All right, thank you for coming. Enjoyed it. Passing these out, I'm going to set them up here, and you can get them if you want them.
Can we give Dr. Wilbur one more hand before I give you the code? Thank you, Dr. Wilbur. And remember that anyone seeking social work CEUs must sign in and out daily at the registration desk. And please go to Groupio, and this is session 28, and Dr. Dave Wilbur. We like an evaluation of some feedback. And the code for today is LOT 224. That's LOT, LOT 224. Thank you so much. See you tomorrow. Anything I need to do?